and welcome to the Board of Administration and Executive Team virtual offsite meeting for the second day. I'd like to start by asking Ms. Hopper to call the roll, please.
Henry Jones.
Here.
Margaret Brown.
Here.
Rob Fechner.
Good morning.
Frank Ruffino for Fiona Ma.
Excused.
Lisa Middleton.
Good morning.
David Miller.
Here.
Stacy Oliveris.
Here.
Nicole Griffith for Irene Ortega.
Here.
Ramon Rubicava.
Here.
Teresa Taylor.
Here.
Shonda Wesley.
Excused.
Betty Yee. Karen Green Ross for Betty Yee. I see they're both in there, but I'm not getting any response.
Okay. Well, we will check on them in a minute, and Ms. Hopper, and but we'll go ahead and move forward with the agenda. And I would like to welcome all of our stakeholders and members of the public who have tuned in today. And I'd like now to turn it over to our CEO, Marcia Frost, to introduce today's agenda. Ms. Frost.
Great. Thank you, President Jones, and good morning, everyone. Welcome to day 2 of our virtual offsite. So this morning we will start with an action item.
This is Karen.
Hi, Karen.
I can't hear you guys. Shoot. Oh.
Are you sitting in, Karen, for Betty today? You just muted yourself.
Can you hear me now?
Yes.
I apologize. I didn't realize my speaker was off, so I didn't hear you doing roll call. And Lynn just told me.
Okay, Karen, are you sitting in for Betty, or is Betty you taking the?
I am sitting in for the controller. Yes.
Okay, thank you so much. I'll mark you down as in attendance.
Thank you.
Good morning again. So this morning we will start with an action item to approve the 2022 health premiums for our HMO and our PPO plans. We'll also review the premiums for the 3 association health plans and the state annuitant contribution formulas for 2022. The team has worked aggressively to get the premiums as low as possible for our participants. The final rates for your approval are lower than national averages. However, we do know that the trajectory of the premium increases is not sustainable. So our work with the health plans and really the direction that has come from the Pension and Health Benefits Committee and the full board is to continue to make bringing down those costs a high priority as we go into negotiations into 2023. And then later this morning, we'll also have an update on our really important work on behavioral health from Dr. Julia Logan. She'll discuss the ongoing challenges with accessibility and our approach to addressing it. And then she'll also provide an update on the impacts of COVID-19 to behavioral health, as well as the condition known as long COVID. And then in the afternoon, Sabrina Hutchins from our Enterprise Strategy and Performance Division will walk us through the proposed goals, the timeline, and activities for the development of the 2022 through 2027 strategic plan. The board will use a new tool, which I think you all have had your training on, to facilitate its approval, its input of the initiatives, and to invite discussion where there are differences in viewpoints. And then we'll also have a special session on the administrative requirements for working after retirement. For many employers, employees who return to the workplace after retirement can be a great staffing resource to them in the short term, but there are a myriad of real rules that must be followed to ensure the member is not only appropriately compensated, but that the employers are following all of the, the rules and the requirements within the PEARL to avoid penalties and fines. So Anthony Sweeney and his team will walk you through the educational resources, the controls in place to prevent violations, which are extremely impactful to the member, which is also the reason that this item is on the agenda. Many of the board members had asked questions after receiving direct outreach from a member who had been impacted. And then the last session today will provide you an informational update about the special election to fill the public agency representative position on the board that was vacated by Jason Perez. And I'd like to just take a quick opportunity to thank Jason for his service to our members and congratulate him on his promotion. So with that, President Jones, I'll turn it back to you.
Thank you, Ms. Frost. Okay, well, first up today is an action item, as Ms. Frost indicated, and that is to approve the health premium rates for 2022. So here to present is Martha Green, Chief of our Health Plan Research and Administration team. Welcome, Ms. Green.
Thank you, and good morning, President Jones and members of the board. Marta Green, CalPERS team member. The 2022 HMO and PPO plan premiums are an action item for your approval. The final proposed premiums have been provided to you in separate documents and are available on the CalPERS website. Attachment 1 is for the HMO plans, and Attachment 2 is for the PPO plans. Both attachments include single party, two-party, and family premiums for state and contracting agencies. Next slide, please. In June, we discussed the program and portfolio changes and major cost drivers that are impacting the 2022 premiums. Today, I will focus on the changes and improvements since June. The first update is the pharmacy rates. As I shared last time, the June rates were calculated using our external pharmacy actuarial consultant. As you may recall, this was because we were working with Optum to correct their pricing to reflect all appropriate contract provisions. I'm pleased to share that we now have agreement with Optum on the 2022 pharmacy pricing. The overall pharmacy rate is very close to what we presented in June. However, you will see some upward and downward impacts on individual plans to better reflect individual plan level trend. As a reminder, this pharmacy pricing update only impacts plans that have pharmacy benefits provided by Optum. Plans that provide or contract separately for pharmacy benefits are not impacted. The non-impacted plans include Kaiser, Blue Shield, Sharp, Medicare Advantage, and one of the United Healthcare Medicare Advantage products. With that said, here is today's agenda. I'll provide a brief recap of our timeline for the premium setting process for this year. I'll walk through the updated statewide average rate increases for 2022 and highlight some plan-specific changes since June. And lastly, I'll share next steps for today and the rest of the year as we work to implement the premiums and prepare for open enrollment. Next slide, please. Here's a recap of the rate development timeline for the 2022 plan year. Last November, the board approved the new risk mitigation strategy for the CalPERS Basic program. In November and March, the board approved new plans and service area expansions for both basic and Medicare products. We presented the initial premiums for 2022 in a May closed session. In June, we presented the preliminary premiums, which included the new program changes. And today I'm presenting the final proposed premiums and will ask for your approval. Next slide, please. We had modest improvements in most categories and overall compared to June. For HMO plans, we see a 4.69% increase in the weighted average, which is a slight decrease of 0.14% since June. This is mainly driven by improved medical pricing for Blue Shield Access Plus, Blue Shield Trio, and Anthem Select. The updated pharmacy projections have upward and downward adjustments to the HMO plan premiums, but have no impact to the basic HMO plans overall. I'll address more regarding that in plan-specific slides. The basic HMO plan premium changes increased by 0.36% since June to 8.67% due to the updated pharmacy assumptions. The total basic program premium change is 5.65%, a slight decrease of 0.03% from June. Our total Medicare program also decreased by 0.32% since June due to the updated pharmacy pricing. With that, our total weighted average change from 2021 improved slightly since June and is now 4.86%. The total weighted average does not include association plans. Next slide, please. Now I'll walk through each plan and discuss the changes in the proposed 2022 premiums since June. Next slide, please. As a reminder, Anthem HMO Traditional is one of the plans whose pharmacy benefits are administered by Optum Rx. The revised pharmacy pricing reduced the overall premium by approximately 0.57%. Before portfolio rating, the updated 2022 premium increase for Anthem Traditional was 12.59%, a slight decrease from the 13.19% I presented in June. Portfolio rating brought the premium down by 8.03% to a 4.56% increase. The projected surplus is approximately $12.4 million as of December 2020 for Anthem Traditional. We recommended using 80% of the surplus to offset some of the premium impact to our members. This results in a 1.82% premium decrease for 2022. Next slide, please. Next is Anthem HMO Select. The proposed premium decreased 1.65% from June due to the updated fee-for-service claims experience and revised pharmacy pricing. Before portfolio rating, the updated 2022 premium increase for Anthem Select is 5.97%. The plan has a lower than average risk score, so portfolio rating brought the premium up by 2.53%. We recommend using 80% of the healthcare fund surplus to reduce the premium increase to 5.94%. Next slide, please. Next is Blue Shield Access Plus. The proposed 2022 premium decreased slightly by 0.21% from June as Blue Shield updated its member migration assumptions for 2022 open enrollment. The premium is now a 4.13% decrease after portfolio rating. We do not recommend using any healthcare fund surplus to bring the premium down any further. Next slide, please. Next is Blue Shield Trio. In June, I mentioned that CalPERS is adopting changes to the Trio formulary that are designed to address low-value prescriptions. The net impact is 2% decrease on net pharmacy costs and a 0.3% decrease in statewide premiums. Blue Shield has also updated the member migration assumptions for Trio. Combined with the formulary change, the proposed 2022 premium has decreased by 1.02% from June. The premium is now a 4.09% increase after portfolio rating. We recommend using 80% of the healthcare fund surplus to reduce the premium increase from 4.09% to 2.79%. Next slide, please. For HealthNet Saluti Mas, the proposed premium increased by 1.05% from June due to the revised pharmacy pricing. The updated premium increase is 22.83% after portfolio rating. The team recommends using 80% of the healthcare fund surplus to reduce the premium increase to 14.47%. I'll add here that even with this increase, Saluti Mas has by far the lowest HMO premium in the basic portfolio. It's 20% lower than the 80/80 state contribution of $607 for 2021. Next slide, please. The proposed 2022 premium for HealthNet SmartCare decreased slightly by 0.05% from June due to the revised pharmacy pricing. The updated premium increase is 8.95% after portfolio rating. The healthcare fund subaccount for SmartCare was in a small deficit as of December 2020, so there's no premium buy down opportunity for 2022. Next slide, please. Kaiser's proposed premium increase of 2.68% has not changed since June. Kaiser's premium change is very modest and one of the lowest in the basic portfolio. Portfolio rating has brought the premium up by an additional 2.97%, leading to an overall premium increase of 5.65%. Because Kaiser is a fully insured plan, there's no opportunity to accrue a healthcare fund balance. Next slide, please. For Sharp, the updated 2022 premium decreased by 0.76% from June due to the updated pharmacy pricing. Sharp has a 6.43% portfolio rating impact due to their lower risk concentration of members. The premium increased by 10.59% overall. Even with this premium increase, Sharp has the second lowest premium in the basic HMO portfolio. The healthcare fund account for Sharp is in a deficit as of December 2020. Therefore, there is no buy down opportunity for 2022. Next slide, please. The United Healthcare Alliance 2022 premium increased slightly by 0.16% from June due to the updated pharmacy pricing. The premium increase is 11.18% after portfolio rating. The team recommends using 80% of the Alliance's healthcare fund surplus to reduce the premium increase to 8.26%. Next slide, please. United Healthcare Harmony is the new basic HMO plan for 2022. The updated premium decreased slightly by 0.04% from June due to the revised pharmacy pricing. The proposed premium for 2022 is $737.35 with a portfolio rating impact of 7.86%. The bar graph on the slide shows the HMO basic plan state premiums. Harmony's proposed premium came in the third lowest, mostly due to being in lower cost counties in Southern California. Harmony has a highly capitated model, which is designed to be more efficient and cost effective, and we will be monitoring its performance in the portfolio. Next slide, please. The last plan in the HMO basic portfolio was Western Health Advantage. The updated premium decreased by 0.58% due to the updated pharmacy pricing. The premium has a modest increase of 1.36% after portfolio rating. We recommend using 80% of the healthcare fund surplus to change the 1.36% premium increase to a 2.08% decrease. Next slide, please. Here are the updated premiums for the two basic PPO plans, PERS Platinum and PERS Gold. The overall basic PPO plan premiums have increased slightly by 0.36% from June due to the updated pharmacy pricing. PERS Platinum will have an 11.68% decrease from the 2021 PERS Care premium and a 15.63% increase from the PERS Choice premium. The 2022 PERS Gold premium is 23.32% higher than the PERS Select premium last year. The team recommends using 80% of the healthcare fund surplus to buy down the 2022 PERS Platinum premium. With the deficit in the PERS Select healthcare fund subaccount, there is no premium buy down opportunity for PERS Gold for 2022. With the recommended premium buy down adjustment, PERS Platinum will have a 14.85% decrease from the 2021 PERS Care premium and an 11.49% increase from the 2021 PERS Choice premium. And the overall basic PPO premium increase will be reduced from 11.31% to 8.67%. Next slide, please. Here we show you the proposed premiums for the total basic portfolio. You'll see here that the premium range is $1,198 to $487. Next slide, please. Moving on to Medicare plans. For plans that have pharmacy administered by Optum Rx, premiums are updated with the revised pharmacy pricing. I'll walk through Medicare Advantage plans first and then the PPO Medicare supplemental plans. Next slide, please. The Anthem Medicare Preferred proposed premium has increased slightly by 0.7% from June due to the updated pharmacy pricing. As a reminder, Anthem is expanding their service area to statewide and add benefit enhancements for 2022. Anthem Medicare Preferred has a modest premium increase of 2.4% for 2022. As a reminder, Medicare plans are not included in portfolio rating as the Medicare program is already risk adjusted. The team recommends using 50% of the plan's healthcare fund surplus dollars to reduce the premium to a 6.05% decrease from 2021. Next slide, please. For Kaiser Senior Advantage, there are no benefit design or service area changes for 2022. The 2022 proposed premium is $302.53, or a 6.76% decrease from 2021. There is no change since June. Next slide, please. Sharp Direct Advantage was introduced in 2021. As I mentioned in June, for plan year 2022, Sharp Direct Advantage will have $0 copays for several services, with the ER visit copay unchanged at $50 per visit. The 2022 proposed premium is $263.85, or a 7.96% increase from 2021. As a reminder, this increase is due to the very small plan size and first year implementation. There is no change since June. Next slide, please. There are no benefit design or service area changes for the United Healthcare Group Medicare Advantage. The 2022 proposed premium is $294.65, or a 5.43% decrease from 2021. There is no change since June. Next slide, please. The table on this slide shows the proposed premiums for the new Medicare Advantage plans for 2022. Blue Shield Medicare, United Healthcare Edge, and Western Health Advantage Medicare Advantage. The proposed premiums for United Healthcare Edge and Western Health Advantage Medicare Advantage increased by approximately 0.7% due to the revised pharmacy pricing. The premiums for Blue Shield Medicare Advantage have not changed since June. The bar graph to the right shows the premiums for all of the Medicare Advantage plans in the portfolio. Next slide, please. In our PPO Medicare supplemental plans, the PERS Platinum Medicare premium decreased by 1.06% and PERS Gold increased slightly by 0.29% from June due to the updated pharmacy pricing. For 2022, we see a total increase of 9.42% in the PPO Medicare supplemental plans. This is mainly driven by the 8.81% snapback from the 2021 premium buy down. The total projected surplus for the PPO Medicare plans is approximately $27.5 million. We recommend using 100% of the surplus to offset some of the premium impact to our members. This will bring the overall premium change from 9.42% down to 5.48%. With the recommended healthcare fund adjustments, PERS Platinum Medicare will increase 0.18% from the 2021 PERS Care premium and 9.14% from the 2021 PERS Choice Medicare premium. The PERS Gold premium is 7.84% higher than the 2021 PERS Select premium. Next slide, please. Here you see all the proposed premiums for the Medicare plans for 2022. Next slide, please. After some time for questions, you will have an opportunity to vote on the final 2022 premiums for HMOs and PPOs. We recommend approval of the HMO and PPO premiums so that work can begin on system changes so that the 2022 premiums can be communicated on a timely basis to the Department of Finance and our contracting public agencies. Over the next few weeks, we'll communicate with stakeholders and post the premiums to the CalPERS website. Our team is preparing for open enrollment, which will be held from September 20th through October 15th, 2021. The new premiums take effect on January 1st, 2022. This ends my presentation, and I'm happy to answer any questions you may have.
Well, thank you, Ms. Green. And I would just like to applaud you for, again, a very clear presentation with a lot of technical and very detailed information, but very easy to follow. So I appreciate that. And also like to applaud you and Mr. Moles and the team for what you've accomplished on behalf of our members going forward. The journey starting back in November 2020 and all of the steps and negotiations that have occurred along the way, I believe you've done the best that you can for our members. So we appreciate your efforts and Mr. Moles and the whole staff for what you have provided us today. So with that, we have a few questions from board members. So we start with Mr. Fechner.
Thank you, Mr. President. I'm prepared to make a motion, but I also have some comments. So I'll make the motion and then have my comments after the vote is taken, if that's okay.
Okay.
I move staff's recommendation.
Okay,
I second.
Moved by Mr. Fechner, second by Ms. Taylor. Discussion, Mr. Fechner.
I think I should wait till after the vote before I make my comment. Thank you.
Okay. Okay, any, Ms. Taylor.
I actually did not second it. It was Ramon that seconded it.
Oh, is that right? I'm sorry. Okay, Ramon, I'm sorry about that. Okay.
So,
go ahead, Ms. Taylor.
and I'm confused. I just wanted to ask Ms. Green a quick couple of questions. So the pharmacy does have an impact, and it looks like it did reduce from when we initially looked at it, but it's different for every plan. So I just wondered, how come? What does that mean? Where does that difference come from in each plan?
The difference is because in June, we had to rely on our external pharmacy actuarial consultants to build the rate. If you recall, we were still in negotiations with Optum over some of the contract provisions that we didn't believe were being applied appropriately. And so without their cooperation, we were not able to build the rate with the full knowledge of their understanding of the claims patterns in each product. And so we had to spread a little bit more evenly across all products without that kind of intimate claim line plan trend level understanding that Optum has of its product. And so once we were able to reach agreement with Optum on the treatment of the various contract provisions, then they produced the rate that we agreed was consistent with what they should with each individual plan level pricing. We had to do a bit of an estimate for June based on what we believed the pharmacy claim projection would be for each plan, but they have a lot more granular understanding of that than we do.
And that's the difference in this month's premiums.
Right. And that's why some went up and down a little bit, but overall it's flat from June. It's just some went up, some went down slightly.
So, okay. So then the new plans with the fewer members, like the trio, And those are just going up. Kind of going up because they're small, right? Is that what you're basically saying when?
Some plan sizes, when they're very small, can have a little bit of volatile pricing in the beginning because one unhealthy member can have like a bigger impact on pricing. And so the larger the plan, the more stable the pricing, the smaller the plan, the less stable. So I pointed that out specifically in the Sharp Medicare Advantage product, because I think the last estimate I saw was 64 members. I mean, it was incredibly small. I think it's grown since then, but it was a
68. Yeah, it said 68, so a whole 4 more.
Yeah, so it's incredibly small. And so when it's that small, the pricing is a little bit more volatile. Trio came in pretty low. It is small, but Trio itself came in pretty low. But we do watch those plans that have relatively low enrollment or are relatively new for volatility.
And then Harmony doesn't have any estimates right now other than what they're giving us because they're brand new, right?
Right.
Okay. And I just want to thank you guys for working so hard, getting Optum in line, getting these rates down. It's noticeably different from when we saw this in June. And of course, these rate increases are unsustainable, as our CEO said earlier. And I'm all for exploring any and all options to continue to bring down the rates while we continue to provide quality healthcare. But again, congratulations. I know this was a lot of work. Thank you very much.
Thank you, Ms. Taylor. Ms. Brown.
Thank you, President Jones. Ms. Gray, my question is with the increases and decreases to PERS Platinum and PERS Gold. If we could get to page 17 of 27 on the presentation. And again, this will be primarily my reason for voting no on this. According to the chart, 142,000 former PERS choice, if they stick with where they are, will move to PERS Platinum and see an 11.49% increase. And then another 109,000 PERS Select members will move to PERS Gold and see a 23% increase. Is that correct?
That is correct.
Okay, but this is just the first of the increases, right? Because and this is what you've told us, we expect to see this same increase, maybe not the same percent, but the same is it the same dollar amount? So do we expect to see $122 increase, or do we expect to see a 23% increase again next year, approximately?
It really depends on the member migration patterns. So we can't predict it down to either the percent or the dollar, but generally speaking, this is implementing portfolio rating halfway. But if people move around between plans, for example, so if people leave PERS Select and choose a different plan, that will change the impact, because then the risk score of PERS Gold would change. So it's generally about half, but without being able to predict exactly where every member will select in open enrollment, there's no way to predict to an exact dollar or percent.
So there's a possibility that the $650 PERS Gold premium could be $770 next year, approximately. And then you also talked to us about plan design changes about these as well. Basically, you said there'll be 2 increases, and then you said that there may be some plan changes and they would feel the same. So where are we on those plan changes?
So we bring to the board in the fall proposed plan design changes, and so any discussion around that would occur in November. We would bring that to you for discussion in November at the November board meeting.
But I assume you already have some ideas of what's going to happen. Is that correct?
We've modeled a number of different options that we will bring to you for consideration, but it will be ultimately up to the board to decide to adopt changes or not.
And what do those models have in them? Those increased copays, increased out of pocket? What does that?
Yeah, that's essentially, so what, in order to change a benefit design, you just change the actuarial value. And so you can do that by changing copays. You can do that by changing coinsurance. Those are the variety of tools that you have to change a benefit design.
Ms. Brown, we'll also over the course of the summer be reaching back out to stakeholders to get input from them about potential benefit design changes. So we're not coming in November with preconceived notions or recommendations at this point.
Yeah, and my concern is that, these people who are on these PPOs, PERS Gold, is because they don't have access to an HMO in a lot of the rural areas. And so, their premiums, are going from $527 to $650 to $770, most likely, plus higher copays, higher deductibles, whatever, we don't know. But we're approving this, I believe, in the dark. And I think it's terrible for our members. Thank you.
I'll add that we share the concern about counties where the only plan available is a PPO. We are moving as quickly as we can to work with our plans to increase the options in those counties. So as you know, there are a handful of rural counties that this year do not have HMOs that will have HMOs or EPOs next year. And we've been engaging aggressively with plans for 2023 already with an eye towards expanding. The PPO, there are multiple concerns with the PPO, including the fact that the costs with the PPO are not as controllable as they are with the HMOs. And that is a significant part of the driver here as well. It's fee-for-service medicine. It's not managed because PPOs by definition are not managed. And that is an ongoing challenge.
I appreciate you trying to find an alternative to this huge increase for these people that are forced into PERS Gold. Thank you.
Okay, Ms. Green Ross?
Yes, thank you, Mr. Chair and staff, of course, for all this really hard work. I know I can't, I'm negotiating on all these complex issues. It's very impressive to even move the needle on this. My first question was sort of back to Ms. Taylor's question about the pharmaceutical rates and how they vary by plan. And I just wondered too, when you're getting either Optum's data or using ours in countering their rates, did you distinguish between chronic illnesses and the use of pharmaceuticals for that and one-off situations that are not recurrent?
So most of the pricing predictions, when you do pricing predictions, are based on expected usage. So you don't, in expected usage, you don't like real big surprise one-offs happen, but they're not part of like a pricing strategy. A pricing strategy is looking at, okay, generally how healthy is the membership and how much pharmaceutical do they use? And so you kind of project and predict that out into the next year. And so those kind of really rare one-offs, like an infant born with an incredibly rare condition, those happen. And those do have an impact on pricing, but they're not predicted in pricing because they're incredibly hard to predict. And also, I should point out that some of those really high pharmaceuticals sometimes are not administered on the pharmacy side. Sometimes they're actually administered on the medical side because they're often done in like a clinical setting. And so oftentimes they're administered on the medical benefit. In fact, we tackled one of those in this past year through one of our plans that actually ended up being the responsibility of the medical group to pay.
Okay, that makes sense. Thank you for explaining that. And then second sort of big picture along lines of the questions I know many of the board members, especially Mr. Fechner, often ask about long-term trends in rates. And it may be too early to know this, but the federal legislation trying to increase transparency to avoid surprise billing you know, some of the articles I've read as some of the data is now being submitted show excessive charges to the uninsured. And obviously there's some process, which I think is really unfortunate to have people go through a process to prove their financial need after they've incurred excessive hospital billing charges. But will that trend help our rates? And because clearly it would seem to me that everybody's paying for the uninsured because the hospitals are, you know, trying to get paid, and the fact that they have been charging such excessive rates to the uninsured is just shocking. So just sort of that trend, will that help? And the fact that California is expanding, assuming the governor signs all the budget bills, the Medicare coverage in California, Medi-Cal coverage to 50 and older.
So on the first point, the good thing for California, since we had such high prohibitions on surprise balance billing, it's a smaller group of folks that faced this very devastating, potentially, situation. And so we're really only talking about our self-insured PPO members on the basic side that were potentially exposed. So what this will do is those members that could have faced a surprise bill of some large amount and then had to pay that bill or negotiate with the provider on trying to reduce that bill, that they will be taken out of the middle. What we do know from when California implemented surprise balance billing legislation, that it did not have an upward impact on trend beyond the normal trend rate that we saw in California. And so I can't say that the exact thing will happen with the new federal legislation, but when we did here in California, AB 72 and the other surprise balance billing legislations, it was not a root cost driver. But you're right, overall in the system, every time that somebody puts downward pressure on one area of healthcare, right, you see upward pressure on other pieces of healthcare. But truly, there's really two major cost drivers, and one's major and one's slightly less major. And the major cost driver for healthcare is market consolidation, and it's when you have, you know, somebody has a captive piece of the market, whether it be a hospital chain or major medical groups, and then they're able to dictate the market prices. And that's really what drives up costs and is why so much of our strategy is around increasing competition. And then the other one that we need to acknowledge is there's some pretty amazing life-changing drugs coming to market that are very, very expensive. And the healthcare system does absorb that. So those are the two kind of big things that are happening right now. But you're right to point out that every time you do put pressure on the system, it's a lever. Other things go up, but it isn't the big one. Yeah, it's not the big one.
Thank you. Appreciate that insight.
Thank you, Ms. Greenross. Mr. Rubalcaba.
Thank you, Mr. Jones. And thank you, Ms. Green and Don, for all the work that you folks have done. I had a very baseline question just to make sure we're on the same, so I understand where we're going. So we're starting the 2-year phase-in of a new risk mitigation strategy, but which I know brings uncomfortable or unwelcome price changes, because we're forcing the premiums to basically reflect the true actuarial value and also recognize the risk factors and all that have you. But also we're introducing new plans and expansions. And I know there'll be further plan designs and also adjustments based on migration, because some people will stay with the plan because they think they have a need for certain specialty care, perhaps. They don't want to be managed. But some people realize, well, maybe, you know, if their costs are equal, more or less, we're equalizing the price of the value, they may do other things. So we're going to see changes in plan design. So my question is, all this effort, which I know has created some, people are accepting it different ways. The whole intent here and the expectation is that we're going to stabilize prices shortly, and people will have, it'll be easier to predict trends, and people want to have some comfort level. Yes, I can see that, if I stay with this plan, it'll go up a certain percentage. If I go, this plan is going more because they're still moving with new populations. So for example, some of the new plans that hopefully will grow, and there'll be migration. So there's still a lot of, I don't want to say laboratory, but a lot of changes are happening, but we're controlling it more than we had before. So it's a long question, but I think what I want to say is we're entering into this phase because we think it's our value and will increase stability for our members, correct?
That's right. It's really going to do three things. It's going to stabilize pricing, as you described, so you can have predictable year-over-year changes. And that is fundamentally because pricing will be tied to benefit design and value of the product, and not to the risk concentration in the product. The volatility in our pricing has been tied to adverse selection, which is the risk concentration in the product, which is why we would have products that would spiral up in price and become unsustainable in the portfolio, while others, because a lot of very, very healthy members don't use healthcare, were in them, will priced well below the cost of healthcare. And so this will stabilize it all and ensure that each product is priced based on its benefit design and the cost of healthcare.
Thank you very much.
I know that all of you know this, but I'll just say it for the sake of others who are listening in on this. This is all cost neutral overall. So there are significant decreases in the costs associated with a number of our plans as well. That doesn't make it okay if you're in an area where your plan is going up significantly, but for many of our members, they are seeing significant price relief as part of this as well.
And if I could add, Mr. Jones, it also, I don't want to say stops the plans from gaming the system, but it makes the plans look at their plan design and try to figure out how can I use our tools to keep our members healthy. And that's how they retain a healthy population and attract members because of quality of service. And that's what they should be compensated for. So
that's exactly
thank you for your explanation and answer. Thank you very much.
Yeah, they will be forced to compete on cost and quality rather than their ability to attract young and healthy members.
I wish I could say things the way you say them. So clear. Thank you, Mr. Remote.
You did.
Okay, thank you, Mr. Rubikow. Ms. Taylor.
Yeah, sorry, I thought I was done, but something else dawned on me. Dawn, I just had a question. This is hard. I mean, I know my members are not going to be happy with some of these increases, but and I think all of us have concerns about these increases, and I know we're working to stabilize these rates, but what other options do we have? Because I just don't think simply voting no because we're seeing one plan or a couple of plans increase their prices while we start to stabilize things. What other options do we have?
Yeah, that's a great question, and that is the question that we spend most of our day working through and on. On the PPO side, as I mentioned, one of the key strategies is getting options into the counties where they're the only option, so that there are lower cost, and that usually means HMO options in those counties. We're working as quickly as we can. I'll remind you of the other strategies that we have been using, such as the competition strategy, which is, so when you look at costs across the state, there is incredible price variation. There are parts of the state where costs are double what they are in the lower cost counties. So, one of the strategy we embarked on with Trio, with Blue Shield Trio last year was to move a low-cost HMO option in with a novel network. There's a single hospital there that has the luxury of charging essentially whatever it wants. It's a monopoly in the area, and we created a network. that allowed us to divert traffic for a lot of schedulable surgeries that can be done outside of the hospital into other settings, which are preferable for many different reasons. We tried to pull that off in Monterey this year. We got very close. We're hopeful that we'll have more success next year, but that is a strategy that we're going to be using in a lot of different places. And the other big issue, these are not, unfortunately, none of this is news. You've heard all of this before, but the other big driver is pharma costs. And we were hopeful, we moved to a novel contract with OptumRx this year. We did not see, we ended up much better than where we started with them for sure, but the prices that we were paying for drugs are still way too high. And we're going to need to work harder and look at more innovative solutions going forward to control drug costs in the future. We are captive to a large degree by larger trends that exist in the United States and that exist in California. We do better than most purchasers. We're able to use our size for leverage, but we're not doing as well as we would like to be. And we still think that there's room for improvement.
Great. So I kind of, basically that's a very good answer to let us all know as board members, we should be working to help you guys mitigate this, whether that's coming to talk to you, giving you ideas on history of our plans, or just, hey, what's going on. But I don't know that it's services our members when somebody votes no on the whole plan, overall plan for our healthcare rates. So like Ramon just finished saying, I mean, ultimately it's looking like we're trying to move towards making the plan design the cost driver and nothing else. And so that's where, SEIU was working with you as well as, I had a lot of questions. I remember calling you and talking to you for an hour, but I think it's important for us as board members to work as hard as we can to bring these costs in line with staff rather than just vote no on the entire process. So thank you very much.
Sure. Let me, if I can, just add one other thing, which is that in 2024, we will be we are on a 5-year contract cycle with these plans. We negotiate rates annually within the contract, but that contract is coming up again. And the other, I think, area where we can look to improve is by, taking a hard look at across all of our plans and their performance. And you're starting to see differentiation in performance between health plans in our portfolio. And that's going to be an important conversation as we move into the renewal process. So that's another big area that I left out, and I just wanted to put a pin in.
Thank you, Don. Yeah.
Don, would you repeat when that contract negotiation starts again?
So it is by and large for 2024, but we start that process in the next couple of months. Marta can jump in and add a lot more detail.
Yeah, we're actually preparing the request for information. So we do a 2-step procurement process. We release a request for information in which we ask plans and carriers to submit to us ideas, kind of what they're doing that's best in class or nation leading. We then assemble all of that information into an RFP in order to solicit the portfolio. And so the RFI should be going out in the coming months, if not weeks. It's actually, it's months. Let me be realistic in my timeline. But we are preparing it right now. So it should be coming out shortly. And then once we digest all of the responses, then the RFP is released. So I would assume that's early next year.
Thank you very much. Okay. We do have a motion and a second on this item, but before we take a vote, we do have a request from the public to speak on this item. So Mr. Fox, can you reach out to the individuals who wish to speak on this item?
Yes, Mr. President, we have two callers. The first caller is Mr. Larry Woodson of CSR.
Thank you.
Good morning, and Larry Woodson, California State Retirees. Can you hear me okay, Mr. Chairman?
Yeah, yes, we can.
Okay, well, thank you for the opportunity to comment. In looking at the HMO basic rates, it's good to see that 7 of the 12 plans came down slightly from the June preliminaries. Shockingly, Kaiser held firm at 5.65% over and 9.5 for out of state. And I guess more shocking is United Healthcare actually upped their increase from 8.09 to 8.26%. I'm surprised that no one kind of focused on that in their comments. As I pointed out in my public comments in June, United Health is number 5 in revenues in the new Fortune 500 list. Their profits soared last year, even during COVID, and they're going to raise rates by 8.26%. That's not acceptable in my mind, and CSR opposes that. In June, Martha Green's presentation demonstrated that besides medical costs, and there's been some discussion today on this, drug costs contributed in many plans to increased premiums. And there was a recent article in Kaiser Health News that detailed a report by the House Oversight and Reform Committee showing that many drug companies, the major drug companies, plow more of their billions in earnings back into their own stocks, dividends, and executive compensation than they do into research and development. The 14 largest manufacturers paid themselves and investors $578 billion from 2016 to 2020 through dividends, stock buybacks, and only $522 billion on research and development. That's 56 billion less, and that's not even counting the what they put into advertising. On top of that, the report said that some of the R&D money is spent researching ways to suppress competition by filing hundreds of new minor patents on older drugs, making it harder to produce generics, and then they retain these brand name patents. So I guess lastly, I would urge CalPERS to support federal laws to mandate drug companies to negotiate rates for Medicare and to regulate drug profits like all other major developed countries do with their drug plans. Thank you for the opportunity to comment.
And thank you for your comments. Mr. Fox.
Yes, Mr. President, we have one more caller. We have Mr. JJ Jelensik of RPEA.
Hello, this is JJ Jelensik, Director, Health Benefits, RPEA. The rates are too high, but I think everybody knows that, but I say that every year and need to get it in there. But one of the issues this year really is the risk adjustment that you're going through. You've chosen a good model if you're an insurance company, but not a good model if you are a consumer. By focusing on payments, which is the easy part, rather than focusing on actual health conditions, you create rewards for paying high fees to providers and punishment for paying low fees to providers. You have created a PPO type incentive program into the HMOs. And most people acknowledge that the PPOs are not nearly as cost efficient because of that incentive. So I recognize that you've made this decision. You're going to go through with it this year. In fact, quite frankly, I don't think you'd have the ability to change it this year. But I really urge you to re-examine the model you're using and see if there is not a better model that helps drive down costs rather than drive up costs. The other comment I would like to make is in response to the statement about the high fees charged the uninsured and surprise billing. I will point out that much of that is a result of private equity moving into the health field in terms of hospitals, in terms of practices, in terms of ambulance services, in terms of air ambulance services. And we really kind of need to address that. And I need to point out to you that you are choosing to use your investment portfolio to help drive that process. So I really would encourage you to, one, look at a new model, and two, really look at how your investments in private equity are creating additional problems for health costs. I thank you.
Okay, thank you, Mr. Jelencic. Okay, so we do have a motion by Mr. Fechner and second by Mr. Rubalcava. Ms. Hopper, would you please call the roll?
Margaret Brown,
No.
Rob Fechner,
Aye.
Frank Ruffino for Fiona Ma,
Aye.
Lisa Middleton,
Aye.
David Miller,
Aye.
Stacey Oliveris,
Aye.
Nicole Griffiths for Irena Ortega,
Aye.
Ramon Rubacava,
Aye.
Teresa Taylor,
Aye.
Shonda Wesley, excused, Karen Green Ross for Betty Yee.
Aye.
Mr. President, I have 9 ayes, 1 no, made by Margaret Brown. Motion being made by Rob Fechner, seconded by Ramon Rubacava, with 1 excused by Shonda Wesley as well.
Okay, thank you, Ms. Hopper. Mr. Fechner.
Thank you, Mr. President. And Mr. Woodson, just so you know, it was not lost on me. I had said that I was waiting for my comments till the end. So I will talk about what you brought up. But I first have a couple other things I'd like to say. First, I'd like to thank Ms. Green and her entire team for the great work that they put in. And I'd also like to thank Mr. Moulds for actually taking the helm while Ms. Green was on loan to the governor. So thank you for the hard work that you put in during that period of time. Staff did a great job. However, they're only one part of the equation. And as I said last month, I wanted all the plans to come to the table with a sharper pencil. And thankfully, a few of them did. We saw a couple of the rates change. I will say that Anthem and Kaiser and Shield seem to have listened a little bit. It appears that Optum listened some, but as far as I'm concerned, it was much too little and much too late. They should have been to the table a lot earlier and a lot more forthright. But my main concern is with United. And I said last month that I was going to call people out if they were not fair players. And I'm a man of my word. So here I am. United, you are not a fair player. You actually not only did not drop your rates and have a sharper pencil, you raised your rates. That's unconscionable. We have to realize that we have members out there that are low income and have areas that they need to protect. They have family they need to protect, but at the same time, they have limited income in which to do so. Our job is to find the best rates we can. And I will say that if your pencil is not sharper as we go forward in the future, my recommendation is that you no longer stay. So this is now up to you. And I know that our members are going to be upset, but they will find another health carrier. On the other hand, you're going to lose 130,000 lives. I'm not sure that's a good business decision on your part. So I would say that you come to the table with a sharp pencil and bring your brightest minds, because we need to make sure that we're protecting our members going forward. Thank you, Mr. President.
Thank you, Mr. Fechner. Okay, that concludes the discussion on that item. So we will now move to association plan premiums, which is next on the agenda for the 2022 Association Health Plan premiums. Ms. Green, please.
Thank you. Good morning again, members of the board. Marta Green, CalPERS team member. The final 2022 premiums for the association plans have been provided to you and are available on our website. Next slide, please. Here is today's agenda. I'll show you the statewide weighted average premium change from 2021. Then we'll review the basic and Medicare plan premiums for the association health plans, then discuss next steps. But before I jump in, let me review CalPERS' involvement in the development of association plan premiums. CalPERS annually reviews and adopts the premiums and benefit proposals for 3 health plans offered exclusively to the members of these associations: the California Association of Highway Patrolmen, the California Correctional Peace Officers Association, and the Peace Officer Research Association of California. The California Highway Patrol Plan is a self-insured PPO administered by Anthem Blue Cross of California. The California Correctional Peace Officers Association is a fully insured HMO administered by Blue Shield of California, and the Peace Officer Research Association of California is a self-insured PPO administered by Anthem Blue Cross of California. The 3 associations are responsible for ensuring that the association plan premiums and benefit changes are appropriate and their reserve funds are adequate for their continued operations. CalPERS does not negotiate the benefit designs for these association plans. There are no benefit design changes for either of any of the 3 plans for the next year, and adopting the association plan premiums has no budgetary nor fiscal impact to CalPERS. Next slide, please. The overall statewide weighted average premium percent change for basic and Medicare plans in 2022 are 2.66% and negative 1.3% respectively. 2 out of the 3 basic association plans propose no premium increase for 2021 to 2022, driving down the weighted average change to 2.66%. For Medicare, PORAC Medicare has a 10.14% premium decrease due to favorable claims experience, while CCPOA Medicare has a 5.83% premium increase. There is no premium change for the Highway Patrol Medicare plan. This drives the association Medicare weighted average change to negative 1.3%. Next slide, please. Here are the 2022 basic premiums for the 3 association plans by region and party group. Next slide, please. This slide presents the association Medicare plan premiums for 2022 by region and party group. Next slide, please. For next steps, we'll communicate premiums to stakeholder groups and post the premiums to the CalPERS website. The association plans and premiums are offered during open enrollment, which is September 20th through October 15th. The new premiums become effective January 1st, 2022. This ends my presentation, and I'm happy to answer any questions you may have.
Thank you, Ms. Green. I see no questions from board members. So then I will check with Mr. Fox to see if there are any requests to speak on this item from the public. Mr. Fox.
Mr. President, there are no callers on this subject.
Okay, well, thank you very much. Okay, well, now we move on to the next item on the agenda is the state annuitant contribution formulas. So our final health presentation is this item. And so that, Ms. Green, you still have the floor.
Thank you again, Mr. President. Marta Green, CalPERS team member. This is an information item on the state annuitant contribution formulas for plan year 2022. The employer contributions for state annuitants are based on the final health plan premiums the board just adopted today. Next slide, please. Here is what we'll cover. I'll provide some background, discuss how the state employer contributions are determined, and present the contribution amounts for 2022. Next slide, please. First, I'll begin by reminding you of a few key terms. An annuitant is a person receiving a CalPERS pension. In general, there are 2 groups of annuitants. Basic annuitants are those enrolled in a CalPERS basic plan, and Medicare annuitants are those that are enrolled in a CalPERS Medicare plan. These 2 groups fall into different state contribution formulas based on their date of hire and their bargaining unit. The 3 state annuitant formulas are the 190 formula that includes basic and Medicare annuitants hired prior to 2016 or 2017, depending on their bargaining unit. Next, the 80/80 formula for basic annuitants hired on or after January 1st, 2016 or January 1st, 2017. And third is the 80/80 formula for Medicare annuitants hired on or after January 1st, 2016 or January 1st, 2017, depending on bargaining unit. The final annuitant contributions were calculated by applying the contribution formulas, either the 190 or 80/80, to the weighted average premiums of the top 4 plans. However, the determination of the top 4 plans is different for each formula. We'll walk through each on the next slides. Next slide, please. Here's the 190 formula. The state pays 100% of the weighted average premium for the 4 largest basic plans for the subscriber and 90% of the additional weighted average premiums for their dependents. The top 4 basic plans for this formula are determined based on total subscriber enrollment across all basic plans in the portfolio. This does not include dependents, subscribers only. The top 4 plans for the 190 formula for 2022 are Kaiser Permanente, United Healthcare Alliance, Blue Shield Access Plus, and Correctional Peace Officers Association South. CCPOA South replaces PERS Choice in the mix of the top 4 basic plans for 2022. Because PERS Choice is being replaced with PERS Platinum for 2022, PERS Choice 2021 enrollments cannot be used for the purpose of developing the 190 state contributions for the 2022 plan year. Therefore, CCPOA qualified as the replacement plan. CalPERS determines the top 4 basic plans and calculates the state annuitant contribution for the 190 formula. Next slide, please. The 80/80 formula applies to basic annuitants hired on or after January 1st, 2016 or 2017, depending on bargaining unit. The state pays 80% of the weighted average premium for the 4 largest plans for each subscriber and 80% of the additional weighted average premium for their dependents. For this formula, the top 4 basic plans are determined based on active state civil service subscriber enrollment, excluding family members. The top 4 plans for the 80/80 formula are Kaiser Permanente, United Healthcare Alliance, Blue Shield Access Plus, and Correctional Peace Officers Association South. For 2022, CCPOA South replaces PERS Select in the mix of the top 4 basic health plans, as PERS Select will be replaced with PERS Gold, and we are unable to use the enrollments for PERS Select. The 80/80 annuitant contribution formula is administered by CalPERS. Next slide, please. The 80/80 formula for Medicare annuitants hired on or after January 1st, 2016 or 2017, depending on their bargaining unit, is similar to the basic 80/80 formula. The difference is the 80/80 state contribution is developed based on the premiums for only Medicare members on state annuitant enrollment in Medicare plans. The top 4 plans are Kaiser Senior Advantage, United Healthcare Group, Correctional Peace Officers Association, South, and Anthem Medicare Preferred. For 2022, California Highway Patrol and Anthem I misspoke earlier. I said CCPOA and I meant the California Highway Patrol. For 2022, the California Highway Patrol and Anthem Medicare Preferred replace PERS Choice and PERS Care in the mix of the top 4 Medicare plans, as PERS Choice and PERS Care will be replaced with PERS Platinum, and we are unable to use the enrollments for PERS Choice and PERS Care. CalPERS determines the top 4 Medicare plans and calculates the annuitant contributions for the 80/80 Medicare formula. Next slide, please. This slide presents a summary view of the information we just covered about how the sums are calculated. Next slide, please. Here are the 2022 state annuitant contribution amounts by formula and plan and tier. Just as a point of reference, for the 190 formula, the 2022 single party state contribution is expected to increase about 2%. For the 80/80 basic formula, the 2022 single party state contribution is expected to increase by about 7%. And the 80/80 Medicare formula, the single party state contribution is expected to decrease about 10%. Next slide, please. That concludes my presentation, and I'm happy to take any questions.
Thank you, Ms. Green. I see no questions from board members, so we will then go to see if there are any one from the public who wishes to speak. Mr. Fox, please.
Mr. President, there are no callers on this subject.
Okay, thank you. Okay, so having reached that point, we will move on to the next item, the behavioral health update. And we'll turn our attention to this item and get an update from Mr. Moles and our Chief Health Director, and Dr. Julia Logan, our Chief Medical Officer. Are you guys ready?
Mr. Jones, if I might interject.
Yeah.
We've gotten ahead of the noticed schedule.
Okay.
And really, we need to pause now so that we can get to the point where we are on schedule with the schedule.
Okay.
So I would suggest that we break until 11:15.
Okay. Okay. So these are not like our regular meeting where it says or earlier after the completion of the previous
Right.
agenda item.
Right.
Okay.
That's one of the problems with the way we schedule these relative to the regular board meetings where we have the committee statements that you just recited.
Okay. 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 That's something maybe we need to look at for our next offsite.
Yeah.
Okay. Okay. Thank you. So we will reconvene at is notice for what, 11:15?
Yes.
11:15. We'll reconvene 11:15. Well, it gives everyone a time to have a breakfast, I guess. Extra cup of coffee. Okay. So to the public, we'll see you at 11:15 also. Okay. Thank you, Matt.
You're welcome.
And next, we'll turn our attention to behavioral health with an update from Don Moles, our Chief Health Director, and Dr. Julia Logan, our Chief Medical Officer. Mr. Moles, please get us started.
Great. Thank you, Mr. Chair. And I was looking for Dr. Logan, and I see her just to my left and one square down. So I am going to turn things over to Dr. Logan, who's going to be providing a COVID update and then talking about the main topic that's next, which is the update on behavioral health. So Dr. Logan, why don't you go ahead and take it away?
Great. Thank you, Don, and thank you, President Jones. Good morning. Julia Logan, CalPERS team member. This morning, I will be providing a COVID update, and then we'll move into the behavioral health update. For my COVID update, I will touch on the state of the virus and vaccinations, the Delta variant, the possibility of a booster, discuss the implications of long COVID, and the recent J&J vaccine warning. So first, the state of the virus, and to use two metaphors simultaneously, we see the light at the end of the tunnel because of the availability of vaccines, but we are certainly not out of the woods yet. As the weather warmed up this year, coronavirus case numbers plummeted. The fewest deaths have been reported since March of 2020. Life in California and the US started to feel almost normal. But in recent weeks, that progress has stalled, and case numbers in some areas with low vaccination rates have started to trend slowly upward. We're starting to see elevated cases here in California as well. The CDC flagged several counties in California over the past week as hotspots, including Contra Costa, Sacramento, San Diego, and Los Angeles. These are places where COVID-19 presents a high burden to the community, measured in part by a significant rise in cases, as well as increases in case positivity rates. As an example, LA County has seen an increase of more than 160% in cases over the past 2 weeks, The vaccination campaign continues, though progress has slowed. Despite ample supply, fewer than 1 million doses are being administered each day across the US. Less than half of the country is fully vaccinated. Here in California, 62.2% of Californians over the age of 18 are fully vaccinated, but there's a lot of variation by age, by county, and even by zip code. For example, only about 30% of adolescents between 12 and 15 are fully vaccinated, while 69% of Californians over the age of 65 are fully vaccinated. Marin County has more than 71% fully vaccinated, while Lassen County has only 21% fully vaccinated. Here in Sacramento County, with less than half of their eligible population fully vaccinated, health officials have reported an increase in cases and have doubled down on immunization efforts and are reaching out by zip code and focusing on pop-up clinics, using trusted messengers, and working with community-based agencies to reach out to those who are left unvaccinated. The infectious Delta variant has become California's most identified strain of the coronavirus. The variant might be twice as contagious as the initial variants of the virus, and based on early studies, it spreads more than 200% faster than the original version of the virus. And this is due to its mutations that increase the spike protein's ability to bind to human cells, thereby increasing its infectiousness and facilitates easy entry into human lung cells. For unknown reasons, the symptoms of the Delta variant appear to be slightly different than other variants. Case reports from the United Kingdom suggest that coughing and loss of smell and taste are less common with the Delta variant, and symptoms like headache, runny nose, and sore throat are more common with the new variant. The good news, the very good news is about Delta is that if you are fully vaccinated, you are extremely well protected. A recent study shows that the 2 doses of mRNA vaccine are about 92 to 93% protective against the Delta variant. However, a new study found that only 1 dose of the mRNA vaccine is barely protective against the Delta, underscoring the importance of making sure that people get their second shot. There's been a pretty dramatic run of events in the past week about boosters, so I'll walk through that a bit. Pfizer announced last week that they were developing a vaccine targeted to the Delta variant and also had promising results from studies of people who received a booster shot. This data has not yet been released, so I can't report that to you, but they did announce that they were applying for an emergency use authorization for a booster. The CDC and FDA quickly countered that booster shots were not yet recommended for the general population because of a lack of data and because more than 90% of new COVID-related hospitalizations were in unvaccinated patients. And about 99.5% of COVID deaths have occurred in unvaccinated people. You may have heard there was a meeting last night with key players from the CDC, FDA, and Pfizer to discuss their differing opinions. Other countries have been using their own real-world experience to update policies on booster shots. Clinicians in France have been recommending booster shots for severely immunocompromised individuals. And on Sunday, Israel's health ministry announced that it would begin offering boosters to adults with weakened immune systems who already had 2 doses of the Pfizer vaccine in light of the rising number of cases that are caused by the Delta variant. There are ongoing studies about if, when, and who we should be boosting, and an incredible amount of work is going on real time. So I suspect that we'll be hearing much more about the boosters over the next several weeks to months, particularly around the possibility of boosters for certain populations. I did want to spend a few moments on long COVID because it was discussed at our last PHBC meeting and because it may have impacts on our healthcare system for some time to come. Although most people with COVID-19 get better within weeks of becoming ill, some people experience new or ongoing health problems more than 4 weeks after first being infected with COVID. These problems can last for many months and are experienced by up to 30% of COVID patients of all ages, including children, even if the illness was mild or if they had no symptoms. This is known by many names, but most commonly as long COVID. People with long COVID report different combinations of symptoms that can impact nearly every organ system, including brain fog, nerve pain, headache, depression, and heart palpitations. Because this phenomenon is so new, much remains unknown about it, and the causes of long COVID are still under investigation. Theories include autoimmunity, damage to nerve pathways, and persistence of the virus at low levels. Long COVID clinics have been started throughout California and the country to provide a multidisciplinary approach to treating long COVID patients. There was some interesting research out of the UK recently that identified so-called autoantibodies in long COVID patients that were absent in people who recovered quickly from the virus. Unlike normal antibodies, which help fight off infections, autoantibodies attack healthy tissues by mistake, causing ongoing damage through the equivalent of biological friendly fire. With these findings, it's possible that a blood test for long COVID could come in the next several months, which could substantially help diagnose and treat this newly evolving condition. In addition, Congress recently allocated more than $1 billion to the NIH to support research into long COVID. It's a really important step for effective treatment for individuals suffering from this condition. We will continue to track long COVID, including its prevalence and treatment, and will include it as a point of discussion with our health plans at QBRs. And one last item that you may have read about today is that the Johnson & Johnson coronavirus vaccine has been linked to an extremely rare neurologic condition called Guillain-Barré syndrome. Of the more than 12 million vaccine doses administered in the United States, there have been about 100 reports of people developing Guillain-Barré. Most were men 50 and older who developed Guillain-Barré 2 weeks after the vaccine. In light of the newly documented risk, the Food and Drug Administration has updated the label of the vaccine to include a new warning suggesting an increased risk during the 42 days after vaccination. Guillain-Barré can cause numbness in the extremities and lead to full body paralysis in the most severe cases, but most people recover and it is treatable or can be treatable. People can develop Guillain-Barré syndrome after some other infections as well, such as the flu, the virus that causes mono, and Zika virus. Very rarely, people have developed Guillain-Barré in the days or weeks after receiving certain vaccines, such as the flu or the shingles vaccine. With that, I conclude my COVID presentation. With your permission, President Jones, I'd like to continue with the behavioral health update and take all questions following the presentation.
That's fine.
Okay, thank you. If I could have the behavioral health slides, please. Okay, so switching gears, and if you can advance to the next slide, please. Today, I will be walking through some of the ongoing challenges that we face with behavioral health, provide utilization and prevalence data from our data warehouse, talk about how we are assessing member experience in new ways, and actions we are taking to address challenges, including quality measures, and finally, some really impactful areas of alignment we are working on with our public purchasing partners. Next slide, please. Since our last update in January, the statewide challenges to behavioral health continue, and many of them we have discussed in previous presentations, including stigma, workforce shortages, lack of appropriate screening for behavioral health disorders, and of course, the impacts of COVID will be felt for the foreseeable future. COVID has really changed the way people think about mental health, and it's transformed the way people are accessing services. There are also challenges we have as healthcare purchasers in assessing the quality of behavioral health. Typically, we use performance measures in our contract to assess and then improve the quality of clinical services. Unfortunately, there's been a lack of nationally recognized meaningful measures for behavioral health. So even being able to evaluate quality has sometimes been a challenge. Next slide, please. Behavioral health continues to be an area of focus for the CalPERS team. We engage regularly with the health plans and pharmacy partners, and we have also taken action in the areas of access and quality to ensure that our members are receiving high quality care. Today, we will walk through those actions, some of which were nascent back in January and some which are in full development now. And we have added some performance measures to our contract, which measures some of the gaps and areas for improvement in care. I'll speak more about those shortly. And finally, access and high quality behavioral health care is a statewide delivery system issue that impacts all the large purchasers and its members. And as such, we must align in order to make progress. I'll talk through some of these alignment areas that have evolved since January that we believe will be transformative on a statewide level and aim to address some of the really entrenched challenges I noted in the last slide. And while it's not listed on this slide, I did want to mention that our efforts in health equity are impacting our work in behavioral health. And just as behavioral health is a strategic focus, so too is health equity. And we recognize the need to keep this simultaneous focus. Next slide, please. As I mentioned in my COVID update, the pandemic looks much different than the last time we presented to you on behavioral health in January. We've made unbelievable progress in understanding, treating, and preventing the disease, but we know that we will continue to see lasting effects of the pandemic throughout our health program, especially in behavioral health. The pandemic has fundamentally changed how our members interact with the healthcare system, and it's taken a toll on people's mental health. And more concerning is that people are experiencing mental health issues, but may not be seeking treatment. According to a Kaiser Family Foundation survey earlier this year, many adults who reported worsened mental health during the pandemic also reported foregoing mental health treatment. About a third of those who reported a negative impact on their mental health say there was a time in the past year when they thought they might need mental health services or medication, but did not get them. In the next several slides, I will discuss the impact we're seeing in our data. We're closely following prevalence, outpatient utilization, substance use utilization, hospitalization, and telehealth. And we will walk you through those areas, and these slides will look familiar because we presented you earlier versions of these graphs back in January. Next slide, please. We've been tracking prevalence rates of several behavioral health conditions listed in this table. The prevalence of many, but not all, behavioral health conditions increased over the course of the pandemic for our basic members. We saw large year-over-year increases in anxiety, depression, and substance use disorder. As you can see, other disorders, including bipolar and schizophrenia, did not increase, and this is actually expected, as depression and anxiety may fluctuate based on certain stressful situations, while bipolar and schizophrenia are much less dependent on situational changes. And our data is actually pretty consistent with national data on the prevalence of anxiety and depression and the impact of the pandemic. Next slide, please. This slide shows the prevalence of behavioral health conditions in 2019 and 2020 for our Medicare members. We didn't include bipolar and schizophrenia on this slide because the numbers were so low and any change year to year was not actually meaningful. Our Medicare members had a slightly different experience in behavioral health over the course of the pandemic. Anxiety increased by about 9%, depression was essentially flat, and substance use disorders decreased by about 10%. Next slide, please. This graph shows the utilization of behavioral health services from the beginning of 2019 through the end of 2020. Utilization had been relatively stable over time. When the pandemic hit in March of 2020, there was an expected dip in utilization, and we see an increase in the last quarter of 2020. Obviously, we're interested in tracking beyond the end of the pandemic because we anticipate that there may be an increase in demand as people become more comfortable again connecting with the healthcare system. We continue to track our behavioral health grievances and appeals to ensure that as utilization increases, we don't see an increase in concerns from our members around limited access or longer wait times. Thankfully, we do not see evidence of delays or impaired access in our grievance and appeals data, and grievances and appeals for behavioral health have showed no significant increases. Next slide, please. In looking at substance use utilization from 2019 through 2020, we see a similar pattern with perhaps a bit more stability. Utilization has stayed quite stable with a very slight drop at the start of the pandemic. Our carriers have reported across all books of business that this trend is consistent. National survey data suggests that the incidence of substance use disorder is on the rise, but people are not presenting to care. It underscores the importance of screening and engagement with members' primary care physicians for early intervention services. We've been following national trends and discussions with our health plans, and we anticipate an increased need as we move past the pandemic. Next slide, please. This next slide looks at substance use utilization by age, and it tells a different story than just looking at our overall numbers. As you can see from the top two lines, those in early adulthood, so adults ages 18 to 45, represented by the gray line, and middle-aged adults ages 45 to 65, represented by the light blue line, are higher utilizers of substance use services and saw a dip early in the pandemic, but a slight rise for early adulthood later in the pandemic. Older adults over 65, represented by the yellow line, and adolescents, represented by the dark blue line at the bottom of the graph, are lower utilizers of outpatient substance use disorder services, and their utilization remained flat in 2019 and 2020. Next slide, please. Behavioral health hospitalization is really important to track because we want to make sure that the need is being met in the outpatient space and smaller, more manageable problems don't become larger and require hospitalization. Historically, about 60% of individuals who admit into the hospital for acute psychiatric conditions have not had any behavioral health treatment 6 months prior to being admitted. This opens the opportunity for earlier intervention to prevent these admissions and assist individuals in managing their health proactively. And this graph of behavioral health hospitalization rates shows us a few really important things. First, that our adolescents, represented by the dark line at the top, are being hospitalized for behavioral health conditions at a significantly higher rate than other ages. This is consistent with the statewide average of behavioral health hospitalizations in teenagers in California, though it is concerning and worth following and discussing with our health plans. It also shows that the rate of hospitalization for all groups has been relatively steady over the course of the pandemic. Again, just to emphasize, screening and early interventions are so key to keeping our members engaged and away from acute hospitalizations, and something again that we are engaging our plans in. Several of our plans are utilizing new integration solutions to embed behavioral health services into primary care, because so many of the predictors for behavioral health admissions really do sit outside the behavioral health delivery system. Next slide, please. So this is the last of the graphs. As we discussed in January, telehealth has dramatically increased over the course of the pandemic, and this graph is showing the sustained and dramatic increase in behavioral health telehealth through 2020. Thankfully, there's a lot of really good clinical evidence that telehealth is an excellent modality for behavioral health services, and outcomes are as good or better than in-person services. It also addresses some of the tough barriers to behavioral health access, including stigma and geography. For patients who have never before sought care from a therapist due to various barriers, including concern about being seen at a physical clinic, the option to obtain services online can be a port of entry into mental health care. Research has shown, and this has been discussed at our last board meeting actually, that patients who receive medical care, especially psychological care, are more open to treatment when they are comfortable with their provider. Telebehavioral health has the potential to allow members to break down geographic barriers and connect with mental health care providers and specialists from a variety of cultural backgrounds, ensuring that they feel at ease with their clinician in terms of shared cultural understanding, reduction of language barriers, and other factors. We've engaged with our health plans regarding the provision of culturally competent care via telehealth. Kaiser, for example, has developed telehealth services to meet the needs of diverse populations, including Spanish-speaking members, transgender, non-binary, and gender-diverse members, and members affected with PTSD, among others. Most member groups have become quite comfortable using telebehavioral health. There are plans that reported that certain groups, especially adolescents, have not embraced telehealth as much as other members have. And we've seen a similar trend in our own claims data. While we have seen an increase in telehealth in teens, the uptake hasn't been as large. We've engaged our plans and how they're outreaching to teens in need. Blue Shield reports using direct face-to-face counseling when the teen is willing. The teenager or parent can simply call a toll-free number to speak with a clinician who will provide consultation in developing a plan and some initial first steps to begin to better manage concerns. Next slide, please. We know that access is essential to receiving high-quality behavioral health services and has been a key area of focus for the health team. In the next several slides, I walk you through some of our efforts to address access and patient experience. Next slide, please. We've identified 3 major areas where we can learn more about our members' access and experience with behavioral health services. The first is our annual health plan member survey. On the next slide, I will be providing more detail about our additions to the survey and lessons learned. The second is our partnership with UC Davis, which I introduced in January, on a survey to our members and focus groups to get more in-depth qualitative information about our members' experiences with behavioral health services. And third is our telehealth survey. that will inform us about our members' experience with access and quality of telehealth services. I don't have as much information to report back on this one just yet, as the survey results are currently being analyzed. Next slide, please. Here's what we've learned from our 2021 health plan member survey results. Of the members who responded to our survey, about 14% on average needed to access behavioral health services. And most of those who received counseling, about 85% felt that it helped them. Thankfully, the rates of ability to access behavioral health services were essentially the same from this year to the last. We added questions to this year's survey about member well-being and mental health screening. We did identify an area of improvement that not enough members are being screened for depression. Screening for depression is a national recommendation, is evidence-based, and the right thing to do for our members. So we need to do better on this. We will be engaging our plans on this particular issue. Next slide, please. In January, as I mentioned, I introduced you to our partnership with UC Davis Health Services researchers to better understand access and member experience related to behavioral health. And this project includes a brief survey to our members that will launch this summer. So if you receive this survey, please be sure to fill it out and encourage your constituents to fill it out as well. The survey will serve two purposes. It will help us better understand the challenges and opportunities to behavioral health access, and it will also help identify members who would be willing to participate in focus groups. These focus groups, led by UC Davis, will help delve into some of the more complex issues and give us a much more comprehensive understanding of the challenges our members face. In addition, we hope to be able to start identifying inequities in care that our members face. Our membership is diverse, and needs for behavioral health are very personal and individualized. We hope that hearing from our members will help us understand better what we need to improve on. Next slide, please. Okay, switching gears a bit now to medications. Management of medications is a really important part of high-quality behavioral health. So we have been actively engaged with our pharmacy partners to ensure our members are getting and staying on the medications they need. In our presentation in January, I noted that our pharmacy benefit manager, Optum, launched an expansion of an adherence program for behavioral health medications in March of this year. We are also monitoring utilization of behavioral health medications, and not unexpectedly, and mirroring national trends, prescriptions for antidepressants and anti-anxiety medications remained high through 2020. Our pharmacy partners, Optum, Blue Shield, and Kaiser, each have a comprehensive and effective opioid management and safety strategy that is evidence-based and in line with national guidelines. Next slide, please. I did want to touch on the issue of opioid use and treatment for opioid use disorder among our members. As the health team has discussed with you in the past, the opioid epidemic has evolved considerably over the past decade. Although the epidemic started out as an overprescribing epidemic, the medical community has since learned a tremendous amount about treating pain and the deleterious effects of opioids, and national and state health policy has certainly played a major role as well. The CDC came out with guidelines in 2016 that really focused on prevention and limiting overprescribing and using opioids in small doses only when necessary. Over the past several years, we, in partnership with our PBM and health plans, have put into place a comprehensive opioid strategy program. As you can see, we have really seen improvement. The arrows are all going in the right direction. Utilizers and claims of opioids have decreased, and prescriptions to treat opioid use disorder have increased over the past several years. We cannot rest on our laurels, though, especially given the reports of increases in opioid use during the pandemic. We continue to have our opioid safety programs in place. We'll need to continue to screen for substance use, and we continue to monitor through our data warehouse and with an opioid key performance indicator in our strategic plan. Next slide, please. What the utilization and prevalence data that I discussed earlier with you doesn't show is the quality of the services provided. Were members receiving high quality behavioral health services? This is where performance measures come in and help us really understand quality. And I mentioned earlier that there were not enough high quality nationally recognized measures for behavioral health. And while that is true, there are a few that are incredibly valuable and align with some of our priority measurement areas with our purchaser partners. For the 2021 contract year, we added 3 quality performance measures in areas that were really important. The first measures the timeliness of follow-up after mental health hospitalization. Research tells us that transition points are a vulnerable time for patients. Having appropriate and timely follow-up ensures that members don't relapse or get readmitted and can address problems or patient and family member questions early. The second measure evaluates whether members are starting and becoming engaged in alcohol or other substance use treatment. Again, our focus here is early intervention for our most vulnerable members. And last, we included a measure that focuses in on behavioral health treatment for children and adolescents, because as we have discussed, this group is often difficult to reach, and early and appropriate treatment is essential to long-term good health. Next slide, please. In previous meetings, we have talked quite a bit about the importance of alignment to drive improvements in quality and access, while minimizing the administrative burden to our plans and providers. We continue in this pursuit with our California partners, and as you recall, Don and I meet with the leadership of Covered California and the Department of Healthcare Services every other week to discuss high priority areas, of which behavioral health is at the top of our collective list. The Department of Managed Healthcare and Purchaser Business Group on Health continue to be important partners as well. And I wanted to touch on behavioral health focused investigations that the DMHC is leading. The DMHC received approval in the 2020-2021 state budget to conduct focused investigations of all full service commercial health plans regulated by the department to further evaluate health plan compliance with parity and assess whether enrollees have consistent access to medically necessary behavioral health care services. A goal of the investigations is to identify and understand the challenges and barriers enrollees may still face in obtaining behavioral health care services, and to identify systemic changes that can be made to improve the delivery of care. DMHC anticipates an average of 5 investigations will be conducted per year, and all full service commercial health plans will be investigated over approximately 5 years. We continue to rely on the DMHC to perform this function of regulator and appreciate this further effort into plan compliance with parity and access. Next slide, please. I'm excited to introduce you all to our collaboration with the 3 public purchasers, because together we seek to better understand the potential we have as healthcare purchasers to impact behavioral health quality and access, and to improve equity and eliminate disparities in behavioral health access and outcomes in California. While there is a need to address the continuum of care for all behavioral health conditions, this project will focus on mild to moderate conditions in recognition of the preventive value of early intervention. This project is multi-phase, spanning this summer to the spring of 2022. The initial learning will lead to a broad menu of potential interventions before narrowing in on the most promising options. The final objective is a report with recommended initiatives for sponsors. The sponsors are Covered California, the Department of Healthcare Services, and CalPERS, to consider, including changes to contract requirements and quality measures. Recommendations will inform our contracting process with our health plans, as well as Covered California and DHCS, so that our contracting requirements can be aligned and impactful on behavioral health quality here in California. As you can see, this is an ambitious project, but it has the potential to make really positive change for the benefit of our members who need behavioral health services. We will continue to update you on our progress on this one. Next slide, please. As you can see, we are deeply committed to providing access to high-quality behavioral health care to our members. We know this is extremely important to you all as well, and we will be providing regular updates to you on our progress. We will continue to update our contract requirements as necessary to improve the quality and access of behavioral health services, and we'll be doing this in lockstep with our valued purchaser and statewide partners. Next slide, please. This concludes my presentation. I'd like to thank you all for your attention and interest. And I'd also like to thank my dedicated colleagues here at CalPERS who contributed to this presentation. It really does take a team effort. With that, I'm happy to answer any questions.
Okay, thank you, Dr. Logan, for the behavior health update. And we do have a number of questions. And the first one is Mr. Rufino.
Thank you, President Jones. And thank you, Dr. Logan, for the superb presentation and update. The question is, we recently saw in the news that the San Diego City Attorney has filed class action lawsuits against Kaiser, HealthNet, and Molina over ghost provider directories. The city attorney alleges that the three plans are giving inaccurate and false providers directories to plan members, making it very, very difficult for them to get care. According to the lawsuit, the problem is especially severe at Kaiser, where nearly 40% of the listings for mental health therapists are allegedly false or inaccurate. So the treasurer has three questions. First, is the CalPERS staff tracking these lawsuits? Second, do you happen to know if these alleged violations are affecting CalPERS members? And finally, does the current plan of work that you just described to us includes an approach for monitoring health plans provider directories, especially for mental health therapists and psychiatrists?
Ms. Logan? Mr. Logan, did you hear the question?
I did. I was wondering if Don wanted to jump in on this one.
Yeah, I can start, and apologies, I froze for just a second. So so thanks for the questions, Mr. Rufino. The answer to the first question about whether we're monitoring is absolutely. So we have, we do not have Molina health plans in our portfolio, obviously, but we do have Kaiser and two HealthNet products in San Diego, Saluti Moss and HealthNet Smart Care, although the footprint of HealthNet Smart Care is in San Diego is very small. But we are there are obviously concerning allegations. We're monitoring. You know, we've looked at numbers, as I mentioned. So you know, we have large population in San Diego, heavy Kaiser membership in San Diego in particular. You know, at this point, there are allegations. We're not the enforcement agency in California, but we stay in constant contact with the Department of Managed Healthcare. Anytime there is an allegation like this to monitor it, but we're looking, you know, we're watching as the proceedings progress, but also working through them as a separate channel, just so we are aware of what's going on. The third question about how we know when an allegation like this, so potentially something like ghost networks, where you have a discrepancies between the paper network and the actual network, is a real challenge in, I should say, network issues more broadly are a real challenge in in behavioral health care. As Dr. Logan has mentioned many times, there are shortages of providers in behavioral health, and there is a challenge. She mentioned this challenge more broadly about measuring both quality and access in behavioral health, and access is particularly difficult. Dr. Logan, and I'll turn it over to her, and she can go into more detail. But one of the issues that she's been working with the UC Davis researchers that she mentioned is specifically over this question of access and network adequacy. So it is something that we're looking at individually. It is, she mentioned the collaborative work that we've been doing with Covered California and DHCS. It is also an issue that those two organizations are concerned with, like us. And as we try to address the larger underlying systemic challenges facing behavioral health delivery and the quality of behavioral health care in California, that will be top of the list. Julia, do you want to jump in and add more?
Sure. Thank you, Don. Yeah, one thing that's really exciting about the UC Davis study that we're doing is that the focus groups, we're really trying to hear from CalPERS members and from actual people. A lot of our data comes from grievances and appeals and the health plan member survey, but we don't really hear people's voices per se. And the focus groups will also be able to get at the question of when people were not able to access services. A lot of times through our grievances and appeals, we hear about problems with access, but sometimes people just try to access services, or at least anecdotally, we've heard that people try to access services but not able to, so seek other means or just don't get care. So we really want to hear about that, and we hope that these focus groups will bring that to light and help us understand the complexity of the issues.
Well, and quickly, Mr. Jones, if I can just add a comment to thank Mr. Molds and Dr. Logan for adding, these performance measure with respect to mental health in the survey. So I think that might help in the long run. And thank you for the answer, Mr. Mold.
Thank you. Okay, Ms. Taylor.
Thank you, Mr. Jones. Thank you, Ms. Logan, Dr. Logan, for the presentation, the COVID presentation as well. I was very interested in that. I did not know the name of that long COVID, that it was called long COVID, but I've heard about it and read about it. But as to the behavioral health, I'm going to bring up a personal experience that I have talked to Mr. Molds about. I have Anthem Select, and I had sought out care. I also have UC Davis Health as my primary care, and Anthem refused to pay my provider because they said that UC Davis needed to pay. So, I mean, we've gotten that fixed since then. They did pay them, but I don't know, I guess, Mr. Molds, I'm not clear on whether or not that's going to happen again when we submit payment again, because of this description of it being capitated and that UC Davis is supposed to pay it. So I'm hearing this from my carrier that UC Davis is supposed to pay it. And then, of course, I get told that I have to take care of this by my healthcare provider, my mental health provider, because UC Davis doesn't pay it. So I'm just a little confused. This might help your survey that you're doing with UC Davis, but it seems like that problem started with Anthem Select. And then in addition, I wanted to add to Mr. Rufino's talk about the San Diego case. I did get a huge list. By the way, these are providers that were given to me by Anthem. I got this huge list of providers, And a number of those providers on that list, it doesn't say what their specialty is, but they do other kinds of specialties and didn't do just an adult, right? They did all kinds of other specialties. So that's a problem on the provider list as well. I don't know how many numbers I went through just to find the provider and then still to get told they weren't going to pay. So I have a real concern about access at that point, because now I'm not sure. The lady I was seeing doesn't want to see me now. So now I have to go find another provider. So I have a problem with this.
Yeah, I can answer. I can answer the first part of your question and then make a comment. So it shouldn't happen again, but it also shouldn't have happened in the first place. So there are different mechanisms for payment depending on the financial arrangements, and when it is a capitated arrangement, that the payment typically comes from the healthcare provider, in this case, UC Davis, rather than directly from the health plan. In a PPO or in a fee-for-service arrangement, that can be different. But the important part is that patients do not belong in any part of that equation, and it should be seamless to patients. And when it's not, that is a failure. So, we were grateful for you to raising it with us so that we could address it. We address it every time we hear of this kind of payment issue for many reasons, including what you just pointed out. It is challenging in an environment where we have shortages of providers. Providers often will contract with or accept patients from insurers who are easier to deal with, or healthcare systems that are easier to deal with, because it is a seller's market among behavioral health providers, because we don't have enough. And so when insurers make it at all difficult for providers, patients can end up right in the middle. The other challenge is that Dr. Logan was talking about stigma and about reluctance to get care. This is a perfect example of the kind of thing that makes people not want to seek care. When you end up in a payment morass like you did, it ends up disincentivizing you to pursue care going forward. So, it is exactly the kind of thing that we're addressing with UC Davis. We're trying to work through these systems. It is exactly the kind of thing that we're talking through with Covered California and DHCS, and trying to figure out better systems for keeping patients out. But even under normal circumstances, what happened to you should never happen to any patient. And it is, I will add, not uncommon at the same time.
That's unfortunate. I will say I appreciate all your help that you helped with. I was also as well.
Yeah, and the other challenge, which is related, is that even good provider directories, change. So providers quickly fill up. So a provider on a provider directory on a Monday could have, could be full on a Friday. So it's with tight just margins of availability. It is constantly an issue. Dr. Logan probably wants to jump in.
I really just thank you for sharing your experience. I know that it's not always easy to share personal experience, but it's valuable, obviously, for us to hear about it, and that's why we're doing these focus groups with UC Davis. So I wanted to express my gratitude.
Well, thank you for helping as well.
And that is UC Davis, the educational institution, not UC Davis, the healthcare system, just to clarify.
Yes, that's an important clarification.
Screen?
Yes, Mr. Jones, thank you. And I just wanted to thank the staff for digging in this comprehensive effort, and because it definitely could be skewed without the focus groups, not everybody responding to surveys necessarily. Same reason why people don't get care when they might need it. So the effort with UC Davis Educational Institute. And I appreciate that Mr. Moltz clarified, because I was wondering if that was triggering our rate increase. So glad that it's independent. But again, the controller would like to thank all this collaborative effort to really digging in and assessing and trying to get to some kind of real insight and standards to address and make sure everybody who needs care gets good access to quality mental health care. So thank you very much.
Thank you. Mr. Miller.
Yeah, again, thanks very much, Dr. Logan, Dr. Holds, staff. Fantastic, great presentations, really timely and important stuff for us. And I won't rehash. I've talked before about some of the challenges our members and my personal experiences with family members when it comes to mental health and in particular with Kaiser, but also some issues with UC Davis medical provider. But what I wanted to mention today was earlier today, there was the mention of these new life-changing drugs. And in the mental health arena, I noticed that on NPR today, there was an interesting little piece about one of these new life-changing drugs for postpartum depression. And of course, it's expensive, but it's so far proving to be very effective and is truly life-changing because it's, when administered, it tends to have almost instant results. And one of the highlights of this story was, though, about the devil being in the details when it comes to Kaiser in particular, that at Kaiser, to get this drug, if you can, requires a much, much more almost prohibitive set of hoops to jump through that it's virtually impossible for a patient or a doctor and a patient to do, in that they require you to go through 4 different drug protocols before you can qualify, and very prescriptively require you to do electroconvulsive therapy, which I won't even go into the details of why I have concerns about that, versus other healthcare providers where they want you to try 1 or maybe 2 other drugs. And most of the other drugs are these serotonin metabolism drugs, and you kind of cycle through various iterations to see if any of them work. And this new drug is a completely different mechanism. And it just seems that, you know, I'm thrilled with all the work we're doing and at the big picture, but it's the little details, like getting a list of providers, none of whom you can really make an appointment with or who would deal with your problem, or finding out about a drug that could allow you to engage with your child in less than 18 months after they're born, but you can't get it because in 6 months you can't cycle through 4 different drug protocols and the mandatory electroconvulsive therapy that Kaiser would require for you to get this new drug that could turn your life around overnight. So I just share that in that it seems like you know, we make some progress, but these providers still continue to figure out ways to put the almighty buck ahead of our members and their patients' lives. And I just commend you and the team for continuing to dig in to fight this stuff. But boy, we've got a long way to go.
Okay, thank you, Mr. Miller. Ms. Middleton.
Thank you, Mr. Jones. And I'll try to keep this very short, but I'm looking at the charts that you showed us on prevalence, and I'll start with the one that has anxiety disorder, depression, substance use, bipolar schizophrenia. Are there individuals that are found in multiple groups, or is this indicating that we have some, or is each one of these individual members that are showing in only one group?
Yeah, an interesting question and good to make the clarification. So these are individuals. They could be in multiple groups. You're right. A lot of people with schizophrenia also have depression. There's also a lot of co-occurring substance use disorder in people with mental health disorders. So these are individuals who could be in multiple groups.
All right. So do we have a sense of what the total percentage is of our members who are accessing behavioral health services?
According to our most recent health plan member survey, about 15% of our members accessed behavioral health services.
That is a very significant number.
It certainly is.
Thank you for that clarification. There on so many different levels, I want to commend Dr. Logan, Dr. Molds, and everyone involved in the work that you have done. I think it's exemplary. And I am particularly grateful to see the reduction in opioid use and the increase in individuals accessing treatment for opioids. That's one of the better trends that I have seen in a number of years. And my congratulations, my appreciation. One of the issues that we know we have with mental health is the access to culturally competent providers, the increase of use of video and technology to do treatment certainly makes culturally competent providers much more accessible on a geographic basis. What kind of efforts are we taking, and what additionally do we need to do to make that technology better known to our members, particularly those in rural areas, and more effective?
That's a very good question. I'm not sure I have the answer for you yet. Cultural competency is something that we're working on as part of our health equity work as well. I mentioned in the beginning that they're inextricably linked for sure. And a member who receives culturally competent care receives better care for them. And so that is definitely our goal. We do know from talking to our health plans that telehealth for behavioral health is excellent for most people, but not all people. As I mentioned, teenagers don't do well, and certain teenagers do better than others. But it's something that we're certainly working on with our plans in making sure that the word gets out that telebehavioral health is an option, especially for people in rural areas, or for people who stigma is an issue or geography is an issue. So we certainly raise it in our QBRs, our quarterly business reviews, and we will continue to do that as well. And certainly with our quality measures, it's going to be something that the plans will need to perform well and improve in. And so having their members access telebehavioral health will be an important part of that puzzle. I don't know, Don, if you wanted to add something.
I would just add that I think the UC Davis work is going to help considerably in this space. So as you saw by the graph that Dr. Logan showed of the trajectory of telebehavioral health, we went from essentially a handful to no members using it as a resource to thousands of members using it as a resource almost overnight. and then we saw a flattening, and then we saw a second increase, which is actually arguably more affirming than the first increase, because you see that second increase in a period where people are starting to get back to regular in-person visits, but we still saw an increase in the telehealth visits. And so a couple of things have changed. One is that people have become accustomed, our members have become accustomed to using this, and so they think of it. The other is that their providers have become accustomed to using it, and they offer it. One of the questions that we were grappling with early days when we were trying to just candidly connect providers with members in any way we could is that happened in really different modalities. It happened however a provider could do it. And so we had some providers who are doing visits telephonically who didn't have access to video services. We had some that were using the services that we had already available but just weren't getting tapped, that are video focused. And what we will learn as we evaluate telehealth is sort of the key pieces of those interactions that worked and the key pieces that still need improvements. And so the hope as we talk to members in those focus groups, as we talk to providers in those focus groups, is that we'll get a better sense of what the gold standard for these kinds of visits are. And as the quality improves, and it has already started to improve, but it's still, there is room for more improvement. It will become a better experience and a more meaningful experience, and that will help as well. So, there are a lot of things that just happened by luck and circumstance that helped the acceleration. And our job now is to not depend on luck and circumstance, but to gather evidence and to build on best practices so that it's a uniformly good experience. And we're confident that in behavioral health in particular, that's going to lead to increased uptake and really improve the care in areas where access was the most problematic, and on some of the issues that were the hardest to get to, like making culturally competent care available in rural areas and so forth.
Thank you so very much.
Thank you, Ms. Milton, and thank you. Okay, I see no additional questions from board members, so we will turn our attention to the public comment. Mr. Fox, do we have any requests to speak?
Mr. President, there are no callers on this item.
Okay, thank you, Mr. Fox. Okay, so at this time, we will take a lunch break and we will reconvene for our strategic plan discussion at 1:15. See you all and have a good lunch. everyone is here. We're switching gears now to focus on strategic planning. Here to lead the discussion about the goals and objectives of our next 5-year strategic plan is Sabrina Hutchins, Chief of our Enterprise Strategy and Performance Division. Welcome, Ms. Hutchins.
Good afternoon, everybody. Can you hear me okay?
Yes, we can. Thank you.
All right. Well, as Mr. Jones said, Sabrina Hutchins here, the Chief of the Enterprise Strategy and Performance Division, CalPERS team. I really appreciate the opportunity to facilitate this session. As in past years, we like to use this July timeframe to review our enterprise strategy with you as the Board of Administration and ensure that we're on the right track. As a reminder, you do receive quarterly enterprise performance reports directly within the Insight platform that support your oversight of the outcomes from our current strategic plan. The Q3 report was published in May, and you can expect the Q4 closeout report in August. This year, as we enter into the final year of our current strategic plan, 17 through 22, our focus will be to look ahead proactively and prepare ourselves for the next 5 years of our strategic priorities. Next slide, please. Today's discussion will include a review of our high-level project timeline and project plan. And we want to share what we've completed to date as it relates to the development of our next strategic plan, specifically to review the proposed strategic plan goals and objectives and conduct an interactive exercise to gather your feedback. Ideally, we want to get your consensus to move forward, answer any questions that you have, and determine if we've missed anything. And then we will wrap it up with next steps, which will include continuing our work to refine our goals and objectives and start developing our strategic measures and business plan initiatives in support of the overall strategic plan. Next slide, please. CalPERS embarked on a thoughtful approach to developing our next 5-year strategic plan over a year ago. This view outlines our high-level project timeline and opportunities in engagement with all of you as the board, as well as our stakeholders.
Followed by pound. Otherwise, just press pound.
You may recall we kicked off our efforts with you last year by sharing this timeline and the steps in our planning process. We are now in the development stage, and as I mentioned, today we are sharing our proposed goals and objectives and look forward to hearing your feedback. Early next year, we anticipate sharing our progress at the Stakeholder Forum and then bringing back to you our formal first reading of the plan, most likely in February, reviewing the refinements from today's session, as well as incorporating the next level of the strategic plan framework that again includes our strategic measures and business plan initiatives. And then our final reading prior to the anticipated launch date of the new plan, which is scheduled for July of 2022. Next slide, please. Since we last seen you in July and over this past year, we've been reviewing and analyzing our current state and engaging with our stakeholders. Over the past 6 months, we used the data that we collected and worked in collaboration with our executive team, senior leaders, and program teams to draft the proposed goals and objectives that we're going to share with you today. Next slide, please. At the center of all the feedback and inputs we considered, we clearly understood that our mission has not changed. We are here to serve our membership, which means deliver retirement and health benefits to our members and their beneficiaries. We took a close look at our current strategic plan to determine what we could build upon and leverage, and we took a close look at ourselves through a peer comparison, workforce analysis, our strategic and operational performance, as well as a risk analysis. Through the current state assessment activities, we looked at our organization's strengths, weaknesses, opportunities, and threats, and identified any trends in the data. We sought feedback from our stakeholders, asking them their perspective of our strengths, weaknesses, opportunities, and threats, as well as how we can partner with them. As in the past, we interviewed a wide range of stakeholder groups, including employer, labor and retiree groups, pension associations, federal and state representatives, and other industry leaders. Overall, we conducted 32 interviews of a diverse representative group. We also conducted an internal enterprise survey that captured our CalPERS team member feedback. And we hosted many senior and executive team workshops along the way. Next slide, please. So based on the various inputs we considered and the analysis we've done, several themes emerged, which validated the need to continue to focus on several areas of the plan. Again, as stated, our mission has not changed, and our focus will continue to be on pension sustainability, paying benefits to our members and beneficiaries, delivering high-quality healthcare, ensuring the customer experience is meeting our customers' needs, taking care of our people, nurturing our culture, and protecting and enhancing our operations. Next slide, please. So based on the feedback and analysis and the themes that emerged, we see this as an opportunity to refresh our current plan, to align Marcy's vision and tone, and build upon a solid strategic framework. Here you see a high-level view of our current plan and proposed plan going forward. We have refined the plan to expand our focus while still addressing the importance of pension sustainability, delivering high-quality healthcare, as well as addressing enterprise risk, stakeholder engagement, operational efficiencies, and our culture and people. As we go through each goal in more details, you will also see the objectives underneath each goal, and you will see how the reduced complexity, risk, and talent management elements will align under the new goal of organizational excellence. Our stakeholder engagement efforts are also very important to us, and we wanted to highlight our focus of strategic partnerships more prominently. And also, most notable, we felt adding a goal focused on our members was important to reinforce our priority, that we're here to serve our membership. We believe this goal will really resonate with our internal team as well as our members and stakeholders. Okay, so before I move into the next segment of this session, I wanted to give you a heads up of the facilitation plans for the next piece. So I'll be taking you through each goal and objective, and then I will take you through an exercise where you will be using an interactive tool to provide your feedback. As I mentioned up front, we are looking for majority consensus to move forward, and we'll plan to bring back any refinements in a future session. Then after each goal exercise, we will open it up for discussion for you and the executive team. And then before we move into the actual tool and I open up the exercise, I'll be providing you some additional guidance and reminders. Next slide, please. So the first goal we wanted to review was our member experience goal. We exist to serve our members, and they should be at the forefront of our strategic plan. This goal focuses on ensuring our members are satisfied through accuracy, responsiveness, and respect. And we will demonstrate this through the following objectives: delivering accurate benefits to our members and their beneficiaries, ensuring our members and beneficiaries receive benefit payments on time, providing timely response and appropriate action to inquiries, as well as enhancing our services, communication, and education tools for our members. Next slide, please. So now we're going to enter into the exercise activity using Mentimeter, which is a web-based program that we'll be using today to help facilitate our discussion for each goal and set of objectives. And we'll be gathering your input using this tool. So a few best practices and tips. Make sure you're using your smartphone is most ideal, but you can also use the browser, whatever works best for you. And of course, the Wi-Fi connection will ensure a speedy interaction. You'll want to make sure that you have all your selections made, and then you're going to click the submit button to make sure that all of your input is counted. Once you hit submit, you cannot alter your responses, and individual responses will not be tracked. However, we will be confirming the total number of votes to ensure everyone has provided their input. We will not know who's voted for what unless you feel comfortable sharing during the discussion. And if you find yourself out of sync with the voting, you can go to the top of your screen and there'll be a button there to take you to the current slide. And then again, I will wait for I believe, 12 responses for participation before we open it up for discussion. So you did receive an email with instructions, and that's where you will find your secure access to the website and your confidential code for this activity. So now we'll open up the exercise for the member experience goal. You'll notice the top line is the goal language, and the following lines are related to each objective. So just a bit more instructions. Well, this is the first goal. We have 5, so you'll get the hang of it as we move along. So again, for each goal and objective, if you agree with the language, you actually don't need to move the circle at all. And you know, agreeing with the language, the overall intent of the goal and the objective is what we're trying to get to here. If you don't agree with the language or the intent and you want to discuss further, then you're going to slide that circle over to the right. Again, we are looking for majority consensus. So even if you do agree, you can still raise your hand for additional comments and questions. So it doesn't mean if we're all good, we're not going to talk about anything. So we will open up the floor. And you'll notice right now we have 1 entry on the scale. And as that scale gets higher in numbers, we'll be able to denote how many votes we have or feedback notations. And the numbers that pop up in the middle is just an average of how many responses we have, not necessarily about the filling of your feedback.
Sabrina, I see there's a question from Mr. Fechner about the email. So I'm not sure if he's having a question how to access the.
And it looks like that came from Cherie to everybody's mailbox. And we have 5 responses totaled so far. I believe President Jones, we only have 9 in attendance today or for this session. So
I know Miss Wesley and I think that was the only one that at this time. I know Mr. Ruffino said he would be late. So that's 2 that are missing.
I can't see all the faces at once, so I just want to be thoughtful of how long we should wait for responses. And we'll give folks just another minute or so, and then we'll go ahead and open it up.
Okay, Rob said he's still loading.
Rob's opening up his email and getting to the link. Thank you for that update.
CalPERS is loading too. After we made our decision, we could just hit submit, right?
Correct. So you're going to, slide each one, do them all first, make your selections.
But if we don't want to change, we leave them alone, right?
Correct. If you like the wording as is, if you agree with the intent of where we're going, you're going to leave on the left-hand side of the scale. So it looks like majority, we have agreement that we're on the right track. And we have 8 of the 9 attendees in response. Okay, so with that, we'll go ahead and open up the discussion for any questions, comments on our member experience goal. And we officially have 9 responses within the tool.
Seems like we still got a couple loading.
So this is our first round. Hopefully that felt fairly simple to use once you got in there and got access.
Yeah.
All right. So for the most part, we have agreement that we're on the right track. So I would just offer to open up the floor, President Jones, to take any comments or questions at this point.
Okay. Okay, we have a question from Mr. Miller.
Yeah, I just on the first one for ensuring member satisfaction through accuracy, responsiveness, and respect. I'm wondering whether you consider access to information about services to be covered in that responsiveness or down in communication, or because that's something that if it's covered in how we define those, I'm cool. But I think that's something that's really important to members, is that they're able to access information about their benefits and everything.
Yes, I believe that access will be part of the fourth or the last objective, if you will. And I would ask Anthony to chime in this particular area if you have any further clarification. And we will, and waiting for Anthony, it looks like he might not be in session. Okay, so well, duly noted. I'm pretty sure that's where it lives. Remember, the next layer of vetting is exactly what we're going to do underneath each one of these objectives, and how we're going to measure the effectiveness of each one of these objectives.
Yeah.
So that can be defined at that next level as well.
And so, okay, is that okay, David?
Yeah, thank you.
And my question is, like, I'm just looking at the second item, deliver adequate benefits to our members and their beneficiaries. Are we assuming that all of these will be evaluated? We don't need to say through a survey to our members?
We do already have specific measurements in this particular area. And so we'll be able to define exactly what those mean for accuracy.
Okay.
But I believe it's through a quality assurance process as well for validating accuracy of the benefits and the calculations that we're delivering to our beneficiaries. That makes sense.
Sabrina, I would say the first two are more quantitative measures that have calculations behind them. And then the second two would be more qualitative, that would be determined by surveys, for example.
Correct. Any other questions, thoughts, or comments for member experience?
I don't see any. I don't know if Rob and Stacy has had an opportunity to load and review this yet.
I do see 10 responses.
Oh, okay. Okay.
Covered the majority of the group.
Okay.
Right, we'll go ahead and move to the next goal. So our next goal is focused on pension sustainability, specifically to strengthen the long-term sustainability of the pension fund. Our objectives to attaining this goal are focused on mitigating the risk of significant investment loss and delivering adjusted investment returns. Both of these actually carry over from our current strategic plan. And then we also plan to continue to have our objectives focused on utilizing an integrated view of pension assets and liabilities, as well as integrating ESG into all investment decisions. And both of these have slightly revised wording for better clarity of the intent of the objective. And then the new objective in this area is focused around minimizing contribution levels and volatility. And as a friendly reminder, in your board material, we did include the current strategic plan alignment map, so you can see exactly what we have in place today as it pertains to the wording and these specific objectives. So with that, next slide, we're going to go ahead and open up the voting tool again. And then just a reminder, the top line is the goal language. The following lines are the actual objectives. Again, if you agree with the language and the intent, you're going to leave your circles on the left. If you want to discuss further, you're going to move them all the way to the right. You're going to vote on each one before you submit the or push the submit button.
Okay, we have Ms. Milton has a comment on the pension sustainability. Ms. Milton?
I can jump in now. I don't think this is nearly strong enough when it comes to controlling costs for employers and making certain that the system is affordable. Minimizing contribution levels and volatility is a start, but we have serious issues in terms of system affordability, and I think we have to be far more aggressive in ensuring that the system is affordable.
Thank you for that comment, Lisa. Any additional comments or feedback here?
Yeah, Ms. Yee.
Thank you, Mr. President. I just had a thought about the fourth element, utilize integrated view of pension assets and liabilities to fund the system. I think we're kind of already doing that. I guess I'm just wondering why it's stated as a goal here. I mean, it just seems to be an underlying principle. So I'm just questioning whether it should be included, unless there's something new that we're saying about this.
Yeah, I think that's a good point, because it's really referencing the ALM process that we're in the middle of today.
Right.
So, always trying to improve that process for the board, for the stakeholders, but utilize may not be the right verb here.
Yeah, it just suggests that it's something new, and I don't know that it is new by any means. We've all been experiencing it. So I was trying to think of a verb, Marcy, as well, but I don't know what that should be. But the point is, we're doing it already.
Right. Okay. Well, we can take that back and see if we can modify it to get more at the adjustments we make every 4 years as we go through this process to consistently, look to how we improve it.
I'm wondering if this is also a place, and I know we put some of the emphasis on risk into operational excellence, but we don't really talk about it with respect to pension sustainability. But can we maybe inject some heightened focus on risk here?
Mm-hmm. Yes. Okay. Yeah, I'll make a note of that.
Okay. Thank you.
Yes.
Okay. Ms. Ortega?
Thank you, Henry. My comments are in follow-up to both Ms. Middleton and Ms. Yee. To Ms. Middleton's point, I completely agree with what she said. And I think I almost don't even understand what it means to say something like minimize contribution levels. I mean, there are many ways you could minimize contribution levels, but I'm not sure they would be acceptable to us. So I don't even, I think it needs to be fleshed out more, like what exactly we're talking about as a goal there. And then on the utilize integrated view of pension costs, I I also need more information there. I think I understand based on the earlier discussion what that is related to, but I don't think utilize is the problem. I think integrated view is the problem. I don't know what the integrated view is. It seems to me you need to sort of spell out more what is exactly happening with the ALM process that results in an integrated view. Those would be my comments.
Okay, and so the number 1 and number 2 is mitigate the risk of significant investment loss is really, a risk action while also minimizing contribution levels and volatility. So for example, you could take on a significant amount of risk that may minimize contribution levels, but that is going to have an impact on pension sustainability. Or you can de-risk the portfolio, which would increase the contribution levels and volatility, probably at a level that would not be sustainable for a public employer. So those things are intended to be a balancing act that this board and the fund has to, take under consideration as we're making these decisions through the ALM. The ALM is really the process by which pension sustainability happens. So we can take this feedback back and see if we can make that, put more clarity around it.
That makes perfect sense. I think, and it could just be the way this is displayed, that they read as these individual statements that then to me in isolation don't make as much sense as they do when you think about it together.
Okay, yeah, thank you.
I agree with that comment too. Okay. Mr. Miller.
Yeah, on basically building on what Ms. Ortega and others have mentioned, when I think about goals, I think about something that is clear and concise enough that it can lead us to targets, and goals are something we should be able to understand pretty clearly what we're trying to accomplish and how we're going to know if we have. And so that may help in trying to craft language for goals. The other thing I just thought of is in terms of delivering target risk-adjusted investment returns. I think really I want to almost have something more like meet or exceed, or meet and exceed, or something that we're not just going to settle for, the minimum of getting to that risk-adjusted return target. Those are like the minimum we've got to do to survive. So that's a thought there for you.
Great, thank you, David.
Okay, Ms. Brown.
Thank you. My comments were very similar to Ms. Ortega's, which was on number 3, minimize contribution levels and volatility. I mean, you can just say don't pay, and I don't think that's what we're looking for. So I have a concern just with the way that statement is written. Because if we minimize them, or like how we had them pay amortize over 30 years. You mean go back, we can swing the pendulum back the other way. So I have concerns about that. And then I also had the same question about the second to the last item. It probably would be helpful next time if we number these, but utilize integrated view of pension assets. And so I just wasn't sure what was meant by integrated view. And so you've got both those comments as well. Thank you.
Great. And I think what we could do on number 1 and number 2 is combine those, because as I mentioned, they're supposed to be in balance. So I think we combine those into a single goal. And then as we put the initiatives for that clarity and context would be more understood.
Okay, I have no other questions from the board members at this time.
Very good. And it sounds like we have the executive team in this session now as well to help respond to some of this feedback, which is great. We really appreciate the conversation, and that's why we're here to get your input. So we're going to go ahead and move forward to the next slide and focus on our healthcare goal. And of course, we heard some really good insights from today's session. We also focused the majority of our strategic session last July within the healthcare arena. So the only significant change we made here was to add the word equity within the goal language to really emphasize the good work the team is doing in this area. So the objectives here are ensure our members receive high quality healthcare, ensuring our members have access to care when and where they need it, and ensuring the care we provide is affordable. So we'll go ahead to the next slide and open up the feedback exercise. And I think the group is getting the hang of it at this point. So you'll go ahead and move the circle to the right if you don't agree with the language or the intent of our strategic priorities. We are looking for a majority consensus to continue our work in these areas, and we look forward to your feedback here. We have 6 responses in the queue at this point. And this might be our easy one because thumbs up, we just talked about this significantly over the past year.
Yeah.
Any comments or feedback in this area?
Yeah, this is the one thing I look at number 1. Well, I guess it's number 1 on the slide about the high quality healthcare, and then looking down where ensure that we provide is affordable. So to me, those two go together. Affordable, high quality healthcare, because you can make it affordable, but then it's not high quality. You know what I mean? Or you could do the other is make it unaffordable, but it would be high quality. So wouldn't those two be stated together, high quality, affordable health care?
Does seem to be quite the balancing act. I will go ahead and defer to Dawn if you have any comments in this area.
Sorry, just unmuting. No, I think Mr. Jones has it right. Both our goals, as I've said in the past, high cost does not mean high quality in healthcare. Often it's the opposite. We are looking for that sweet spot where we are identifying high value is the term that we use, healthcare, which is high quality and efficient. It's supposed to be embedded in all these goals, but happy to clarify.
Okay. Okay, then we got Ms. Yee.
Thank you, Mr. Jones. I agree with your comment. I'm just looking back at the goal language where the active verb is improve. And so I think combining high quality and affordable, and if we had a more common understanding of high value, I would even suggest that. But I think high quality and affordable kind of go together. And to Mr. Ortega's point, I think taking these in isolation, it really does miss the point. And then the remainder element really speaks to access. And I think this is where it really speaks to the member experience. So I like just maybe having 2 very kind of robust elements to this goal.
Okay. Ms. Ortega?
No, I didn't have a comment on this one.
Oh, you did? Okay. Maybe that's a no one then. I'm looking at. Okay, let me go down.
You missed me, Henry.
Okay, Ms. Taylor.
I think I'm on the same page as you and Ms. G as well, because our goal language is improve healthcare quality, equity, and access and affordability. And then we have these 2 sub goals, which is ensure the high quality healthcare and ensure members have affordable health care. So it seems to me that we don't need the extra. I mean, I get why we break it out because we work it separately, I suppose, but I'm wondering, that's the main thing we have is ensuring high quality, affordable health care. So, and access, of course, but it says it in the main goal language. And then if the other language, I don't know. It seems to me that we would have it together. That's where I'm at.
Yeah, I mean, you know, the one thing that we've broken this down into the three sort of sub parts. So it is intended to be an overriding goal, and then the three parts, which are, you know, I've talked about this in the past, but they're roughly equivalent to the, you know, the triple aim in healthcare, which is you know, which we've talked about in the past. It's quality, access, and affordability. So, you know, it's why we've done it. You're exactly right that it's captured in the first, and the second are sort of pillars for individual initiatives, which you aren't seeing here, obviously, because you're getting a high level view. But that's the reason for the structure. But I certainly don't have any disagreement on any of the substantive points that you all have raised here. And it's, I think we're rowing in the same direction with this, and we will work to tweak a little bit to clarify that a little bit more.
Mr. Miller?
Yeah, I was kind of where I was going is you've got this overarching goal for high quality, affordable health care, and then we've added this issue of equity up at that you know, goal level. But I think breaking out the three elements without breaking out something for equity, if indeed that's what drives us toward some specific objective or qualitative targets or measures. On the other hand, I could just as easily see equality being related back into the access question, and not needing its own objective or target. So it could kind of go either way. We've got all kind of issues about equality, whether it's rural, urban, different parts of the state, different plan differences available to different people, but and then demographic issues and cultural competence. So I'm not really sure where we're really going with equality, but it may or may not need to be its own objective and have its own measures or targets.
Yeah, I mean, equity is embedded really in all of these goals. So, you know, equity and quality are highly related. You cannot have a high quality health benefit, for example, without it being equitable, because what it means essentially is that it is of lower quality to some of our members. So it's access also plays a large role. So we put it up in central first goal for a couple of reasons. One is for the reason I just alluded to, that it really is, you know, is core to a lot of really everything that we're trying to do here. And the other is to signal that it's a priority. You know, yeah. We've put a lot of resources and effort into the equity work that we've launched and talked about in the past, and wanted to signal that it is critical going forward.
Yeah, I guess what I'm just suggesting that then if it is, then we should spell it out, and we should have measures for it, and we should hold ourselves accountable to defining what we mean by it, in terms of objectives, measures, targets, et cetera, as we flesh out our plan.
Yeah, agreed completely. And you're not seeing that at this level you're not getting the grant here, but completely in agreement on that point.
Don, I was just going to add that this is
Marcy, before you go, Teresa?
Yeah.
Teresa? Okay, Marcy, would you take the gavel on this? I'll be right back.
You bet. Thanks, Henry. I'll keep trying to get Teresa as well.
Okay.
Okay.
I'm right here.
So-
Sorry, guys. I couldn't hear it.
Oh,
You
you're
guys
back.
froze
Okay.
up for a minute. Sorry.
Okay. All right. So Don, I was just going to reinforce a point that you made for David Miller, that there is significant amount of work happening on the equity side with strategies with the health team. And so because this is a strategic plan, we want to highlight those strategies so that we report out every quarter the progress that we're making. So I would like to see, in looking at this, having that equity piece maybe as the fourth goal, just because there's work happening, proactive work.
Yeah. Because I can tell you that, that's the kind of thing I look for as an examiner is there alignment between the overarching goals, objectives, targets, strategy, and that piece appears, then it kind of disappears in the discussion after that level. So thank you.
Yeah.
Thank you for that. And then just to also on that topic, reinforcing the structure here, the top line in this exercise is that overarching goal. This is what we want to achieve over a long term. And then the following are the objectives, our strategies to make that happen. So how we're going to achieve that goal.
Thank you. Okay, I'm back. Thanks.
I was going to say, Lisa, I think didn't talk, right?
I've not, and I do have two comments on this section. The first is the use of the word equity. Yet what we're trying to accomplish with that, but it is becoming one of those words that means many things to many different individuals, and I'm not sure that it captures the depth of the kind of conversation that we had this morning regarding behavioral health and some other groups that have historically been disadvantaged when it comes to the delivery of healthcare. So perhaps equity is enough, but we on behavioral health are taking some really important steps, and I want to make sure that continues along with other efforts to ensure that culturally competent healthcare is delivered to all of our members. My second comment is the focus here in all of these is referencing members and referencing care that we provide. And one of the things that CalPERS has been very good at over the last many years is being a partner to efforts to improve the quality of healthcare delivery in California and in the United States. And I think we need to continue to have a major focus on systemic changes to the healthcare delivery system. Thank you.
Excellent point.
Okay, I don't see any. Mr. Miller, have you already talked?
Yeah, he did.
Okay, all right. Okay.
Yes, plenty.
Okay, thanks. Okay, go ahead.
Okay, moving right along then. Our next goal that we want to focus on is our focused in our stakeholder and employer arena, and we want to be a collaborative partner by promoting collaboration, supportiveness, and transparency. The first objective here will continue from the current plan, and today this actually resides under the fund sustainability goal, and we've revised the language slightly to improve the clarity and intent. In the new plan, this objective seeks to educate and engage stakeholders on system impacts, including policy and program changes, risks, and mitigations. And then the second objective would focus on enhancing services, communication, and education tools. With that, we will open up for the exercise and discussion.
The only comment I have, the subtitles of the goals that you have listed here make sense, but collaborative partner is, I could interpret that to be broader than what we're describing under our goals. Collaborative partner could be our investment partners. It could be federal partners, other pension fund partners, but the narrative, when you get to the detail, it's, I think it's right, but the heading, I think, may be a little broad for what it means here.
Thank you, Mr. Jones. Point taken. Any additional comments or thoughts here?
Mr. Miller?
Yeah, I'm not quite sure how to articulate, but I'm kind of looking for the concept of kind of dialogue, either in the first or second one, somewhere between, educating and providing information in a kind of one-way direction and collaboration. There's got to be some step where there's a dialogue to build shared understanding before you can then kind of promote and collaborate. And it's kind of an in-between step between the kind of the educate. So I don't know. It's just something I kind of look for sometimes.
And David, I think on the collaboration side, we mean, that early access to decisions before they're made, that we're sitting down with our stakeholder groups on a regular basis, talking about the real issues with them, again, before any decisions are made. So, we will make, obviously, if it's not clear, we need to put additional context in there.
Yeah.
And then I think go ahead.
Oh, yeah. I guess I'm just saying the dialogue is a step toward collaboration. And to me, collaboration implies more of an active doing something together. So just, kind of an intermediate step that kind of can be included as part of how you do the education is through dialogue leading to the collaboration. But it's just one of those steps that I think often gets kind of skipped over, and you end up with organizations with a lot of kind of one directional communication, and then a gap, and then an expectation of action on the part of stakeholders or others. And it just helps to kind of emphasize there needs to be that dialogue to shared understanding before you have the ask of support or communication to their members or whatever with stakeholders. So just a thought.
Sure. Yeah, we can definitely break that.
I'm glad you highlighted that, because what I will let you know here is the second line here is actually a translation from our current plan. So that's not what we had planned to put up on the scale. And so to your point of engagement, we actually changed it to read, educate and engage stakeholders on system impacts, including policy and program changes, risk and mitigation. So that kind of speaks to that dialogue piece, that interaction. So maybe I can get one of my team members to type that into the chat just for clarity. And we will make sure to make that revision going forward.
Ms. Middleton, did you want to make additional comments or just stay with what David said?
I think David said it very well, but I'm going to be very specific to the employer community, where historically CalPERS has a reputation of one-way communication. I think that has changed for the better in the last many years, but we need to continue to emphasize collaboration, and then education becomes so much more possible.
Yeah, I think that's a very, very good point. There was certainly a time where we did receive a lot of feedback from our employers that they didn't feel like they had access to the team. So.
Okay.
Good.
Yeah, no,
we appreciate the feedback. Any other comments on collaborative partner?
I don't see any.
Moving right along. Our final goal is to discuss organizational excellence, and we'll focus on cultivating a risk intelligent and innovative culture through our team and our processes. We will accomplish this goal through the following objectives. First, we have enhanced compliance and risk functions throughout the enterprise. This objective is continuing from the current plan as a key ongoing strategic priority from our risk management goal. Next, we have several objectives that are continuing from the current plan as well, with intentional revisions to sharpen our focus. One is improving processes, operations, and advancing technology to enrich efficiency and productivity, to recruit and retain, diverse talent to meet organizational priorities, and to enhance team member engagement and the employment experience. In addition, we have added focused objectives to integrate and sustain leadership competencies to promote behaviors that retain and engage a high-performing workforce, and cultivating diversity, equity, and inclusion through culture, talent, investments, health equity, and supplier diversity. With that, we will move to the next slide, which opens up our feedback exercise. And we'll go ahead and give you a minute or two to, now we split this one up because it has 6 objectives underneath the goal. So this first view is focused on the goal language, so the intent of our long-term effort. And then you have 2 objectives underneath it. We'll start here, and then we'll move to the next section of this goal. The entries are coming in. We're up to 4. All right. We'll open up the floor for any feedback or comments here.
To read, Miss Taylor?
You can call me Teresa.
Okay.
Enhance compliance and risk functions throughout the enterprise. I just feel like that's not answering that question real well. Enhancing the compliance and risk functions. Because risk and compliance has been a kind of an issue. So I guess maybe I'm asking more than saying that the language isn't correct. What is your view of enhance mean for this?
This is Marlene. Can you hear me?
Hi, Marlene.
Hi. Good afternoon. So what we're looking at in enhanced compliance and risk functions is really continue to integrate the compliance and risk activities that are being done throughout the organization. And so I hear what you're saying about enhance. I don't know if integrate, or I think someone had said enrich. I don't know if enrich, but it's really about bringing those activities together that are being done throughout the organization. So they're done sort of at the first level, at the what we call the operating level, first line of defense, essentially, and then also at the second line level as well. And so I think what we're pointing to when we say enhance compliance and risk, it's really about integrating and then awareness, because we also have initiatives around awareness of compliance and risk activities, and we do surveys as well, so that individuals, we do it both on the internal and the external side, that they're aware of the compliance and risk functions that are done within the organization.
And Marlene,
enhance, integrate, and educate.
Well, I think, Marlene, if you could talk a little bit about the maturity assessment that we do, which I think is likely where enhance came from, is that we do assessment on an annual basis, and then we make enhancements based on, those scores. But can you talk about that, please?
Sure. So since I want to say 2017, we have been doing an assessment, a maturity assessment. And essentially the assessment is a way that we can track the maturity of our programs on both the compliance and the risk side. And so each year, as part of our plans actually that we bring you in April, the plans that are actually developed using the results from our maturity assessments that basically tell us what are the things that we need to do in order to bring us to a higher level of maturity. And so to Marcy's point, the enhance could come from the work that we're doing on the maturity levels to essentially each year add to and I was going to say improve, but develop maybe the compliance and risk functions, the activities that are being done within those compliance and risk functions.
Okay, I'm not adverse to the language. I was just trying to get a kind of a definition because I feel like that's a real broad word. So like I said, that's fine. If that's where you're at, I was also thinking educate and something else maybe, I don't know. But if that's what you're in this development phase right now, and that's where you're using that language, it makes sense to me.
Okay.
Mr. Beckner?
Yes, thank you. My question is on the goal language. When it says culture through our team and processes, is the board considered part of the team? If not, I think we should spell out the board.
Yeah, so the board would not be defined in that team word. So if the board would like to have us add a responsibility for you specifically in this goal, we would be happy to do that.
What's your pleasure, Rob?
Well, I just think that we need to be, cultivate a risk intelligent and innovative culture within our board as well. That feeds into the whole system.
So is that something that we should put in our board self-evaluation then, as opposed to here?
Wherever you think is best, but I think if we're gonna ask our staff to do that, then I think we should be asking ourselves to do it as well.
Okay. Any other comments maybe on that thought about having we deal with that in our board self-evaluation area?
We can put it in board self-evaluation.
Okay.
I mean, I think, yeah, if we keep it separate, it probably works a little better.
Okay. So that's a to-do item there. Okay, we have Mr. Miller.
Yeah, on the third one, improve processes, operations, and advanced technologies to enrich efficiencies and productivity. The construction is a little bit confusing. The word enrich kind of seems like an odd word to choose. And when it comes to improvement, I think of improvement in terms of efficiency and effectiveness, the performance of processes, operations. And productivity to me is a measure of efficiency, productivity, cycle time, those kinds of measures. So the efficiencies and productivity seem almost, it seems a little confusing and redundant, along with enrich. So I don't know if that applies to the advanced technologies or just the processes and operations. So I think a little bit of attention to the construction of that could help it. And the addition of effectiveness has got to come before efficiency. So just my nitpicky way of thinking about things.
Okay. I think we could change enrich to gain. That's what this really is intended to do, is to improve your processes. And on the productivity side, as you know, working through process improvement, particularly using lean, you're removing waste in that process that is not an added customer value. So that would automatically increase productivity, which was the thinking behind the construction of this.
Yeah. And to be clear, that the efficiencies don't come strictly from advancing technologies. They go with improving processes, operations, so effectiveness and efficiency.
That's why we put technology third, because
Yeah.
sometimes we like to throw technology at something
Yeah,
before we look at
that's
the process.
exactly. Thank you.
Appreciate that feedback. Thank you. Any other comments on this first piece of organizational excellence? All right, moving to the second piece of this goal. And these are the additional objectives that I summarized in the first slide. So I'll go ahead and give you a minute or two to enter your feedback.
What does it mean on the second one? It talks about cultivate diversity, equity, and inclusion through culture talent. What is that? Culture talent?
We missed a comma there through culture.
Oh, okay.
Investments. The 5 pillars of the DEI framework is what we're reflecting here. Thank you for that.
Oh, okay.
I'll open it up for any additional comments
Ms. Brown?
No, yeah, that was my thing. So my number would have been back over because I thought, what is culture talent? What is that?
That's a new one.
So no, I just figured it was some language I didn't understand. So it's probably would go back to like 1.1, not 1.2 if you pushed mine back. But all right, that was it. That's all I want to know.
Thank you.
Okay. I don't see any other comments.
Good, moving right along. All right, so that was pretty easy. We did really good. Thank you so much for your feedback and input. A little sneak peek into a tool that maybe can be utilized for future sessions to help facilitate capturing your feedback.
We're all becoming technologically astute, right?
I know, it's fun. So over the next 6 months, our goal will be to refine based on your feedback and then really develop that next level of the strategic plan framework. So how are we going to measure our progress of these goals and objectives? What will those targets and thresholds look like? And then what's the work that we need to do in order to accomplish those goals and objectives? So that's articulated through our annual business plan as well. We want to bring back a stakeholder update at the forum in January, and then a first reading to the Board of Administration in February. So we really appreciate your time. Unless there's any other comments or questions, I'll turn it back over to you.
Okay.
Yeah, I think Henry, since we do have a little bit of time here, maybe just an open general question about whether these strategies are comprehensive enough. Is there anything missing that we did not think of, the stakeholders did not provide input on? And maybe invite that conversation with the board at this point.
Okay, well, we could, any board members, you heard Marcy's question, if you want to make any additional comment. And then we do have a place to hear from stakeholders too in a minute, so we'll see if there's any comments from them. But are there any comments, additional comments to Marcy's comment from the board? Ms. Yee?
Thank you, Mr. Jones. while I understand and appreciate that this is a strategic plan for CalPERS as an organization, I think in going through all of this, what felt missing to me is kind of the global nature of our work. And I'm not sure how to express that or how to kind of bring that out. But that just was a missing, it felt like there was a void there. It was very insular, which I guess strategic plans by nature are, because it does speak to how we look at our operations going forward and our mission and how we deliver on that. But that was just kind of a missing kind of context for me in all of this.
Yeah, thank you, Betty. We had contemplated that as well, because we've been defining culture in 5 ways, right? So the members, the team, the efficiencies, the reliable partner. And then that 5th one is the innovation and the best practice leader. But what is our role in leading on the investment side, on the healthcare side? And so I understand your point and appreciate it very much. So we'll go back and take another stab at that one.
Good. Okay, good. David?
Yeah, it's not so much for this higher level discussion, but as the plan gets built, I think it's going to be really important when we get down more to the brass tacks of tactical stuff and planning to deal with some of the threats that we've been challenged with over the last few years that impact our reputation and the way we are seen by our peers, the press, our stakeholders, our members, et cetera. And from my perspective as a board member, I think it's important for us to be, if not considered part of the team, considered part of the organization in terms of what we can do as a board, because I think in some ways, we could do more on that front as well as a board. So.
Okay, any other comments from board members? Before I go to the public to see if there are any requests to speak. Okay, I see no additional questions from the board, so I'll now ask Mr. Fox whether or not there are any requests from the public to speak on this item.
Mr. President, there have been no callers on this subject.
Okay. And so, given that, we have an agenda that's posted for 3:15. So we will take another break and see you all at 3:15. Okay. And next up, we have a presentation about the administrative requirements for working after retirement. Here to present are Anthony Sweeney, Deputy Executive Officer of our Customer Service and Support Team, and Renee Ostrander, Chief of our Employer Account Management Division. Mr. Sweeney, please get started.
Thank you. Good afternoon, President Jones and members of the board. I'm Anthony Sweeney, CalPERS team member, and I thank you for the opportunity to present to you today on the administration of our Working After Retirement program. I know that many of you speak to retirees, employers, and stakeholders that are affected by this program. So we thought it would be informative for you to have a high-level overview of the rules and restrictions related to working after retirement and the consequences when a violation occurs, as well as what controls, communications, and resources are available to members and employers to prevent these violations from occurring. We also want to share some upcoming changes that could affect the program going forward. Next slide. Thank you. I did want to make mention to the note on this agenda slide at the bottom that we will mainly be speaking to those rules affecting members who seek post-retirement employment after taking a service retirement. For disability retirees, these same rules can apply, but there are additional rules that we could talk about in much greater length if we had the time. However, I'll just simplify by saying the laws for working after retirement positions sought by a disability retiree require the duties performed by that retiree to be different from the positions they disability retired from. Other than that, many of these rules apply in the same fashion. With me today is Renee Ostrander, and Renee oversees our Employer Account Management Division, which is responsible for the administration of the Working After Retirement program. Renee is an expert in this area, and she's going to cover the rules and violations and take any questions after she completes that part of the presentation. Then she'll turn it back over to me to speak to our controls, outreach, and changes, and then we'll be happy to take more questions at that time. So with that, I will turn it over to Renee.
Thank you, Anthony. Next slide, please. Okay. All right, so I'm happy to be with you today to provide some education and background surrounding the post-retirement employment world. As Anthony mentioned, we'll first discuss the ways a retiree can return to work at a CalPERS covered employer without reinstating, and then cover the restrictions that must be followed when employed by them. Finally, I'll cover the consequences for the retiree should a violation occur. So should a retiree wish to return to work without reinstatement, there are essentially two paths available. The first is they can fill what we call an acting or interim assignment. A common example would be a chief financial officer at a city or a general manager at a district. If the recruitment isn't complete and or a temporary replacement is not identified internally at the time of the member's separation for retirement, an employer can choose to request the new retiree return in an interim capacity. But as you can imagine, there are some restrictions. First, the employer must pass a resolution prior to the effective date of the retiree returning. The resolution must include several items. One of those is identifying the duration of the appointment. That duration becomes important because a retiree cannot be appointed to that same vacancy twice. So using our prior example, if a retiree is appointed as an interim CFO during the employer's recruitment, they would not be able to extend the duration if the recruitment isn't completed by the time the duration identified has been reached. To assist employers, we do provide resolutions on our website to aid them through this process. Those resolutions, when unaltered, cover all of the requirements necessary for pursuing that option. A more common route, though, is the utilization of retired annuitants for extra help. Examples of this could be bringing back retirees to help with a backlog or a special project the employer would like to pursue. We also saw this during COVID with retirees helping to fill gaps when employees needed to be out of the office or were unable to perform their work activities. Next slide, please. Okay, so once an employer determines the type of appointment it will be, both the employer and retiree need to ensure they abide by the different restrictions provided for in law. The most critical is the break prior to returning. There are both federal and state rules that apply to this situation. The most recent restriction was established with PEPRA, the Public Employees Pension Reform Act of 2013. PEPRA requires retirees to have a 180-day break in service from retirement till beginning a retired annuitant appointment. Of course, there are some exemptions that have been established. One example is the one we just discussed with the interim appointment. An employer is able to file a resolution identifying the retiree has specialized skills and is needed for the immediate return. Another more commonly used example is in the safety area. So if a public safety officer or firefighter retires, they can be brought back immediately if they are returning to a safety position. However, all of the exemptions listed in law do not apply if a retirement incentive has been received by the retiree. And those retirement incentives could come in the form of a golden handshake that's offered through CalPERS, or it could be something that is outside of CalPERS, like a cash offer between an employer and a retiree. The second requirement is actually based in federal law. As a defined benefit plan, members are required to have a bona fide separation from their employer. For those under a normal retirement age, the federal law defines a bona fide separation as no written or verbal agreements prior to separation. In state laws and regulations, we have defined bona fide separation as a 60-day waiting period. We're often asked, what is normal retirement age? The normal retirement age for CalPERS members is defined in regulation as the highest formula age for any given member. So using our prior example, we discussed the public safety officer is exempted from PEPRA's 180-day break. However, we would need to review the service credit for the officer to determine if they are still subject to the bona fide separation restrictions. If the officer had prior service credit in a miscellaneous formula, say 2 at 55, for their time in academy, or possibly part-time working in their community, or maybe even a full-time position prior to joining the academy, their normal retirement age would be 55, not 50, despite the fact that a majority of their service credit was under a safety formula. Of course, there are exceptions to this piece as well. If the governor declares a state of emergency, for example, we've seen with the wildfires or the earthquakes that we've experienced in the past, the state rules for the 60-day break is waived. But the federal piece of no verbal or written agreements is not waived. Next slide, please. All right, so the most commonly known restriction for retired annuitants, which I think everyone talks about, is the 960-hour rule. So state law defines the maximum hours, the maximum number of hours that can be worked by a retiree is 960 hours each year. And those hours are measured by fiscal year. So it resets every year on July 1st. A question we often get is whether it applies to all employers or if it's 960 hours for each employer per retiree. And the answer is that all hours worked for CalPERS covered employers by the retiree during that fiscal year. This can happen in more urban areas where, for example, a building inspector might work for multiple employers as a retired annuitant handling excess work for a limited period of time. They have the skills to perform the duties and just apply the different rules based on jurisdiction. So for them, if they're working for multiple cities, for example, all of that time would be gathered together to determine the 960-hour limit. As we've seen recently with the governor's executive order related to COVID and others related to wildfires and earthquakes throughout the state, this hourly exclusion can be lifted during the emergency. Another requirement is pay. The pay a retiree receives must be no more or no less than what is posted for that position on the salary schedule, and the pay must not include any additional benefits. In our experience, we have seen employers pay longevity pay or even shift differential pay to a retiree because those were items of pay the retiree received when they were active with that employer prior to their retirement. However, those items cannot be paid to a retiree. They can only receive the rate of pay on the salary schedule. Next slide, please. Okay, another topic that comes up for us that's always of interest is in the retired annuitant space when they're asking the question about whether a retiree is in fact an independent contractor or is working as a retired annuitant. A common scenario is that an employee will work for years or possibly even decades for an employer. They retire and then they come back under a contract or agreement with an employer to operate as an independent contractor. In discussing this, the first thing we're quick to point out is that a true independent contractor is not subject to any post-retirement employment restrictions. However, what we often see in these situations are retirees that return to their former employer and operate in much the same or similar manner as prior to leaving that employee, still subject to the control over their work. When we evaluate these situations, we look to the common law control test to help with the analysis of the situation. The primary factor is who controls the manner and means of their work. There are also secondary factors that are reviewed. The intent of the relationship is just one of the secondary factors considered, meaning the utilization of a contract does not create an independent relationship. We provide educational handouts to aid our employers in reviewing these situations to best determine whether it is one of an independent relationship or more of an employment relationship. We also offer our services to employers to review a drafted contract and provide feedback on how the situation appears based on what they've provided to us. Noted at the bottom of this slide, we do want to acknowledge that it is possible to have a retiree and a prior employer create an independent relationship, but in our experience, it isn't common to see it created successfully in that manner. And I know I've thrown a lot of information at you in a pretty quick time, so it's probably a good place to pause and to answer any questions related to the options to be able to work and the restrictions I've talked about. President Jones, are there any questions I can address at this time?
Not at this time. You may continue. Oh, wait a minute, we do have one just came in. Miss Taylor. Teresa, are you muted?
Okay, there we go. Am I unmuted now? Sorry.
Yeah, you're okay now. Okay.
The last slide where you're talking about independent contractors, and then this note down here, possible to be a true independent contractor working at a CalPERS covered agency, same or different from active employment critical retiree and employer understand rules and consequences for violations. So they still do fall under some of these rules.
So yeah, so that's what I was explaining, is that even though it can be established, and we want to make it clear it is possible to establish that independent relationship, but oftentimes what we see is that individuals come back and the only thing that has changed in their environment is that they've created a contract agreement to provide services, but really the work that they're doing is still of employment in nature. So it's still the employer controlling the manner and means of that work. So that contract and that intent is only one factor that we use in evaluating whether an individual is independent or is an employee. And so if we determine through the common law control test that they are an employee, then they are subject to all the retired annuitant rules, and oftentimes run into issues of violation because the pay, most commonly in those situations, the pay is higher than what was on the pay schedule equivalent to the job they're doing.
Okay, so you're saying even if they were an independent contractor when they retired, a fully independent contractor, and they come back as an independent contractor, but for themselves, then they would fall under that?
No, so if they retire if they retire through CalPERS, it doesn't matter what they were doing just prior to retirement, but when they retire, if they would like to come back to a CalPERS covered employer, they must be certain that the relationship that they are establishing is one of an independent nature. Otherwise, they are subject to these rules. Does that help?
Even if they're an independent contractor before retirement?
Well, the independent nature doesn't matter if they're retiring from CalPERS, the independent nature before.
Okay, so if they're so say they left and retired from the company they worked for, not CalPERS. So they're a true independent contractor. That's the point I'm getting at. And then decide to come back and offer their services personally and get a contract signed.
They can still do that as long as it is a true independent relationship.
Okay.
So it is possible, and they can go through, sometimes we'll even see that they will go through third parties to offer it. So like you're talking about going through someone else versus offering it directly. Either way, it still comes down to us applying that common law control test to that relationship to determine if that relationship is truly independent or if it's one of an employer-employee relationship.
Okay. I think I got it. It's clear as mud.
Yep, that's usually what happens.
Okay. No additional questions at this time.
All right, great. Okay, next slide, please. Okay, so when we communicate with a retiree and explain that there's been a violation, the most common question is always, what does this mean? Or what are the consequences to me because of this? And while Anthony will speak later to potential changes in the law, currently a retiree must be reinstated to active membership from the date of the violation until the time they separate from the position. If the position isn't covered by CalPERS, they're reinstated to an inactive position. They also must pay all of the retirement benefits from the point of violation to the time of separation. Oftentimes, these issues can be found much later and can cause a much higher overpayment for retirees. For example, these issues can turn up during an audit or in an ethics complaint years later. With the new penalty put into law a few years ago for employers being required to report retirees and the penalties associated with not reporting, our employers have become much more compliant with reporting their retired annuitants. So we can aid both employers and retirees in tracking all of these items and potentially minimize consequences, but still it can occur and it can be very significant if it's found years later. In addition, the retiree must also pay for the contributions due for the active period. If the violation wasn't immediately found, this would mean that they would have contributions due as well as the retirement benefits for what could be a significant period of time. Once a retiree reinstates, their COLA restarts when they retire. So if a retiree's been retired for, say, 6 years, they could be receiving a double-digit increase in their allowance related to COLA. At re-retirement, their overall allowance could be lower because they don't receive that COLA any longer and they have to begin the rebuild of their COLA from scratch. So I know a lot of questions can come up related to consequences. I think that's probably where we typically get most of our questions. So I thought I'd take just a quick pause to see if anyone had any questions on that prior to moving into some of the improvements that we've been making over the last few years.
There's no additional questions at this time.
Okay, thank you. Then I'm going to turn it back over to Anthony.
Right, thanks, Renee. Guys are letting us off too easy here. So we've always had a lot of controls in place to mitigate working after retirement violations, but we've made a conscious effort to enhance and expand those controls in recent years. First, I wanted to talk about system controls in place that have updated online My CalPERS accounts and our internal tracking systems. These controls allow a member or employer to self-educate and monitor their own compliance. The first item we speak to here includes a display of the normal retirement age of the member, which, as Renee mentioned, is critical to know in meeting the waiting periods before returning to work as a retired annuitant. Next, we have also added the monitoring of hours to online accounts that combines hours work for all employers if a retiree is working for more than just one employer. So this occurs for both the employee and the employer online and tracking those hours through a My CalPERS account. And then lastly is more of an internal system control. And we're continually triggered for all retirees who have been reported in excess of 960 hours, so we can identify and notify of those violations immediately, even if the retiree or the employer was not monitoring themselves. Typically, when violations are caught more timely, the impacts of the consequences, such as those Renee described in the previous slide, are much less impactful to the retiree. So even in the situation of a reinstatement, if you catch it, say within the first year of the member's retirement, those type of COLA impacts and paying back retirement are much less impactful to the member's overall allowance when identified quickly. Next slide, please. So even if a member or employer chooses not to self-serve themselves with the information available, we still have several push communications we make to both the member and the employer to keep them informed of rules and potential violations. For example, once a retiree is enrolled by an employer as a retired annuitant, we trigger a letter to that retired annuitant about their appointment and the associated rules. So they know up front, right when they take that position, what the requirements are. Then once an employee starts approaching that 960-hour limit based on the reporting by the employer, letters are triggered to notify that retiree at 600 and 700 hours so they don't overexceed that 960 hours. We used to send these letters at 800 and 900 hours, and we received a lot of feedback from our retiree population that Sometimes those came too late in the game before they could adjust their hours. And so we moved those letters up to be a bit more proactive in notifying them and allowing them to make those adjustments. Also, we highlight working after retirement rules in both our member and employer publications that reach our member and employer populations. Many of these are updated continuously, and the groups are notified via emails or alerts with the updated changes. So they're very dynamic. We can reach out to those various groups with new information that comes along at any time. Then we have our circular letters, and our circular letters are a key form of communication with our employers. For example, we recently issued circular letters to our employers on the governor's executive orders that were related to working after retirement. So Renee touched on those when the governor's orders on the COVID relief came out, we were able to issue those. And then more recently, when they lifted some of those restrictions or some of the restrictions were put back in on the 180-day waiting period, we were able to electronically send out a new circular letter keeping employers informed of those changes. Lastly, we're requiring our members to acknowledge they're aware of the working after retirement rules by adding statements to our paper and online retirement applications so our retiree population can do more to become self-aware of those rules. Next slide, please.
Okay, Mr. Sweeney, I think we have a question based on.
Sure, happy to
at
take
this point. Ms. Brown?
Yes, thank you, Mr. Jones. You know, all of this assumes that payroll is reporting the hours to CalPERS.
That's correct.
Except for the very last piece you said where you're putting it now on the application form for retirement. But, and that was, I know I heard from a number of people who got caught up in the last, you know, working after retirement audit that you had. And for some of them, the school district, let's be clear, didn't even report them as a CalPERS annuitant. And that's typically, I know at least one of the cases was because the gentleman worked for the city and then he went to work for the school district. So the employer, the payroll lady didn't even know that he was a CalPERS retiree. So they were just paying him like an hourly or whatever. I mean, it's kind of crazy. But what I'm hoping is that, I'm glad you've got it on the retirement form, but I'm hoping that we could even put something on their, you know, check statement or something when they first retire that says, if you're gonna work after retirement, blah, 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 blah. Something that really catches their attention because, you know, sometimes when we have to go back to work after we retire, it might be because we've got some sort of financial burden or other crisis. And so we're not necessarily tracking hours. I know it's our responsibility, but it's also the employer's responsibility to report that back to CalPERS. And so even though it's the employee who gets bit, the employer has some responsibility. And so I'm wondering, of the violations, and I think we discussed this several years ago, I mean, many of them were at the same employer. You know, it wasn't just like, I mean, some of them were one-offs, but a lot of them were at the same employer because the payroll staff didn't know. What are we doing to ensure that that payroll staff, that district or that employer is doing it correctly now?
So you caught me one question ahead, Ms.
Oh, okay. But if you're gonna talk about that, but maybe we can think about sending something even just occasionally on the pay stub, and maybe that comes from Ms. Yee's office and she issues those pay stubs. But just something that says, you know, if you're working after retirement, there are rules. Don't do it, or just some little warning that pops up every now and again to remind them, because it is pretty scary when this happens to you. and then the other question I had was, I'm glad to hear that we're telling people right away when we find this error. I don't think that was happening before. And so a lot of time had elapsed, which allowed people to keep working beyond the 960. Yeah. I don't know if that's true or not. That's what I heard. And so I think the more timely we notify the annuitant that, you know, they got a problem, the better it is for everybody, you know, involved.
Correct. And we're being more proactive. I think we're relying on the member and employer to monitor a bit too much, and we need to take a more proactive responsibility in that. And that's what we've been doing over the last couple of years, and you know, being able to identify those a lot sooner. Also, the legislation that Renee touched on it, that went in a few years ago, that penalizes the employers for not enrolling their as they hire a retired annuitant. We've seen a lot greater compliance once that legislation went in to actually apply those penalties to the employers as well. And we will look for those opportunities. I know we have an opportunity on our retirement acknowledgement letter to include that language on working after retirement, and then those pay stubs, as you said, where we have a message of the month that we work with the state controllers on to put timely updates. So, you know, a lot of them are on a monthly basis, are kind of scheduled out, but we can carve out some opportunity to put those on a statement periodically as well.
Yeah, I think that would be helpful. I see Controller Yee shaking her head yes.
Yes.
So, or in agreement. I think that's great. And then hopefully, you know, we are continuing to do these audits of the employers. And then I hate the stick. I prefer a carrot, you know, well, actually candy, but, you know, I prefer that we try to encourage them to do the right thing as opposed to just the penalty. I know when they get the penalties, I hear from the employers as well. But, and I think we have these sort of constant, you know, these certain group that, you know, kind of always fall down. And those are the ones we really need to aid and assist. That I know, I'm sure we're doing all this, but I just want to hear that we are doing all that, that we're the ones that we've known kind of have a reputation of making mistakes or making these same errors over and over and over again. It'd be helpful to get to them. And that's usually with districts that have, or employers that have a lot of turnover, right? They just have a lot of turnover in their business office. And, you know, payroll is one of the lowest paying jobs in a school district. And as soon as you get that job, you look for a way to get out of it. I can tell you that personally. And so, you know, anything you can do just to, you know, provide incentives and to assist our employers would be helpful, because a lot of times, even though it's the employee's responsibility, typically they're not just paying attention to that. Thank you.
And this slide will cover some of that information, so happy to share that.
Thank you.
Any other questions?
Not at this time, Mr. Sweeney.
Okay. I'll go ahead with slide 10. It was a great intro to that slide. So not only do we provide these push communications and self-service tools on working after retirement, but we also embed these messages in our training and education tools to our members and employers. So this information is a regular part of the employer and member presentations that are delivered by our customer education and outreach division, which are often delivered at employer work sites. We've been doing those virtually, obviously, in today's world. And those can be tailored to a school district, as you mentioned, Ms. Brown. They can be tailored to any specific employer. And then when those members attend our workshops, which we do many of those workshops, that information on working after retirement is contained in those presentations as well. And then we've also been conducting, this is something new we've added more recently, is we've been conducting quarterly webinars for the employer community. where they can learn about these rules and restrictions and interact with our team with questions and answers. So there we put a blast out to all employers, and this has been great in the virtual environment as well, because more employers, especially when you get into those smaller employers and the districts under the County Office of Education, have been able to attend these webinars and really interact with the team. And we've gotten a great attendance at these webinars. And then another method is Renee and I regularly attend these employer leadership dialogues that we conduct around the state. Typically, we visit our regional offices at least once a year across the state. And we've taken those virtually again over this last year. But this is where we speak to high-level officials in our employer community on the proper administration of the Working After Retirement program. And this is always one of the key topics we speak to those employer representatives. And then we continually update information on the CalPERS websites. We have employer guides that are continuously updated. And then we have publications for both members and employers outlining all the rules of working after retirement. And I provide those details a little bit later in the presentation. And then from an internal perspective as well, we're continually updating our processes and procedures to ensure consistent and timely processing for when an issue arises or to prevent any issues from arising. Next slide, please. So besides all our outreach, I wanted to briefly update you on some potential changes on the horizon with the Working After Retirement laws and regulations. So as you're aware, the board took a support position on SB 411 in April that would allow some flexibility in administering the consequences of the violations. The current law is very rigid in applying the consequences of certain violations, such as exceeding the 960-hour limit. Someone who exceeds the 960-hour limit by 1 hour for one period must be treated the same as someone who continually exceeds the limits excessively and for multiple periods. So the passage of this law would allow the team to assess a violation as indicated by current law, but not require a reinstatement, which then creates additional hardships to the retiree. So besides that potential statute change, an additional change that will come your way for review in September is a regulation that will provide clarification on the term limited duration that creates difficulty in the understanding and administration of working after retirement rules for members, employers, and the CalPERS team. So we all have difficulty in interpreting that term as it relates to working after retirement. So the regulation that we currently have vetted with stakeholders would define limited duration to a 2-year retired annuitant appointment with the option to extend that appointment for 2 one-year additional periods. So it's a 2 + 1 + 1 appointment duration. So when creating this regulation, we look to other public retirement systems and our own data to help us define what would be best in this term. And while the majority of our other retirement systems do have durations, they can vary greatly. So we reviewed our retired annuitant appointment data and durations, and we recognize that this 2 + 1 + 1 approach would address the vast majority of how annuitants are currently utilized by our employers. So that kind of 4-year time frame really takes care of the majority of positions that are utilized by our employers. So next slide, please. So just in closing, I wanted to provide some resources that any member or employer can utilize to gain more knowledge or information if they have questions. So as you know, calling our contact center before taking a retiree position, or for an employer before hiring a retiree that is of concern, is always an available option to any member or employer. And then in addition, employers can send employment agreements or questions about hiring a retired annuitant to our Working After Retirement email box for review prior to entering into that employment in question. And then lastly, on our website, we have access to 2 publications, one for both rules related to working after retirement information, or for the option of reinstating from retirement instead, which sometimes can be more beneficial to the retiree than actually taking a retired annuitant position, if that's available from both the employer and the member side, or the retiree side. So we hope all this information that was provided gives you a foundation of the Working After Retirement program and the myriad of rules that are involved, but also the efforts that we are taking to educate and communicate to mitigate issues to our retirees and employers. And we're happy to take any additional questions at this time.
Thank you, Mr. Sweeney, for the presentation. And I don't at this time see any additional questions from board members. But before we go to the public, I do have one question myself, and that is, are you going to share this information with the retiree organization so that they could also publish this information in their publications that go out to their members?
Yes, absolutely. We routinely attend the stakeholder briefings, the retiree roundtables, where we try and give updates on any changes to these rules. And we've worked with them before to help publish articles in their stakeholder communications, similar to the ones that we put in our perspective or our employer news. And love to work with them in any way possible to keep this information flowing to their members.
Thank you. That's great. We have another question. Mr. Miller?
Yeah, thank you for the comprehensive presentation. It's very complex, and I'm glad we have experts like you and Ms. Ostrander to help us out. But I have a question. It's I don't know if it comes up very often, but whether you have any particular concerns or opinions. In my experience, sometimes state agencies, and I'll stick with those that I'm most familiar with, use retired annuitants and bring them back in a position or classification that is several levels down the food chain from where they were serving, but they don't actually use them. For example, they bring back someone who's a division chief as an AGPA, but they don't really use them as an AGPA. They use them as a special consultant, division chief level kind of expertise. And is that a concern, or is that just a nice workaround for agencies to be able to save some money and bring someone in to do work that otherwise they would have to have someone at that level of experience and salary to do?
Renee, you want to share some of your experiences?
Yeah,
we do a lot of that.
Yeah.
So.
Yeah, so state agencies do have the option. They can bring them back under a special consultant position that has a varied salary schedule, or they can bring them back under the classification of an AGPA. So they should be doing the duties associated to the position that they're coming back in. So for example, if they're bringing them back under an AGPA classification, then they should have a duty statement that is applicable to that position for those similarly situated that are under active employment. And then they should be performing those duties to do the position. The special consultant is a little different because I know you mentioned special consultant, and those have a little bit more of a range. And so, but the duties, whatever the duties are related to, that is what they should be performing.
Yeah, the special consultancies were typically paying them what they're worth, but yeah, I was just curious because it seems like there's not really a practical problem or remedy for folks who are, we all know that people's duty statements and what they actually are doing in the office sometimes don't exactly match up perfectly. But yeah, I was just curious about that because I've seen a lot of cases where we had someone who was, who would be way overqualified to be an SSA or AGPA, but it worked out for them and worked out for us. I just wanted to see if there are any concerns about that.
Well, I was going to say, we have seen some individuals that they retire from a higher level position, say a manager 3, and but they choose to come back and just work part-time as an analyst. There's obviously other state rules around restrictions around being able to hire people or retired annuities supervisor and oversee people. Instead, they can be brought back at a lower level to do those analyst duties. And we have seen that, and they will operate, as an analyst. They're obviously well experienced from their past, and so the employer naturally gets a bonus for what they bring to the table. But we do see that there are individuals that are managers or are other leaders that will come back as an analyst and perform that work.
Great.
And Anthony, I don't know if you had anything to add.
Yeah, I was just going to say it becomes difficult to police.
Yes.
Mr. Miller, for us, but when the audit team goes out in the field and is able to do a more detailed review, that's where they might see some of those discrepancies. But it is very difficult to police.
Yeah, great. Thank you very much for your responses.
Yeah, I have another question. If a person retires from an employer and then subsequently is elected to be a school board member or a city council member, how does that work? I know years ago they were part of CalPERS, but are they still part of CalPERS? And how does that work?
Okay, I'm gonna. All right, so I'll start that out. So for elected positions, and depending on the positions, they're different because there are some of those positions that are exempted and so are not part of CalPERS. But just in general, elected positions that have the ability to elect membership, how that works is that if you have separated from all positions and you then retire, you can, if the opportunity is available for you once you are elected into a seat, if that opportunity is available, you can elect, but that requires the reinstatement back into active membership, whereas you can be in the position not elected and be excluded.
You can serve in that position, Mr. Jones, without the retired annuitant consequences. As long as you don't elect optional membership.
I see. So that means that you could have just looking at a 9-member school board where some would have opted out and others would have taken a different option. They could have different benefits then on the same being both elected? Okay. Because it's their option. Is that what you're saying? Okay. Okay. That's that question. Okay, I don't see any additional questions, Mr. Sweeney and Ms. Ostander. So why don't we then go to the public to see if there are any requests to speak? And for that, I call on Mr. Fox.
Yes, Mr. President, there are no callers for this subject.
Okay, well, thank you very much. Well, that concludes this agenda item, and our next agenda item is posted for 4:15. So we will see you in a few minutes when the clock hits 4:15. Okay, thank you very much for the presentation again. welcome back. Our final session of the day is about the special election we'll hold to fill the vacant public agency representative seat on the board. Here to give us an overview is Dallas Stone, and he's the chief of our Operations Support Services Division. So welcome, Mr. Stone, and please proceed.
Thank you, Mr. Jones. Good afternoon, members of the board. Dallas Stone, CalPERS team member. This information item provides background and the tentative special election schedule for the board's consideration in filling the vacancy resulting from board member Jason Perez resigning his seat. I would like to offer you some background on the seat vacated by Mr. Perez before speaking on the tentative special election schedule. On January 16th, 2019, Mr. Perez was elected to the public agency member representative position on the CalPERS board. Mr. Perez's term was set to expire on January 15th, 2023. In June of 2021, Mr. Perez resigned from the board, which created a vacancy in his position. The public agency member representative is elected by all active CalPERS public agency members. Ordinarily, the election to fill this position would be held in 2022 concurrently with the state and school member board elections. With regard to an election following a vacancy on the board, the Public Employees Retirement Law provides that the board shall hold special elections to fill vacancies which occur during the term of the elected members of the board. If at the time a vacancy occurs and the unexpired term is less than 2 years, the new member elected to fill that vacancy shall hold office for a period equal to the remainder of the term of the vacated office plus 4 years. There are less than 2 years remaining on the unexpired term of the current vacancy. Therefore, the new member elected to fill this vacancy will hold office through January 15th, 2027. Special elections are conducted in accordance with our board election regulations. This means that before a special election is held, a notice of election, which includes an election schedule, must be presented to the board for approval. CalPERS is currently engaged in the 2021 member-at-large board election. Voting will conclude by September 27th, 2021. Ballot processing and tabulation, including announcing of unofficial results, is expected to be complete on or around October 1st, 2021. The tentative schedule for the special election, which you can see in the agenda item, has been outlined to avoid overlap between the current member-at-large board election and the special election. Overlap could result in confusion among voters and difficulties in management of workload for CalPERS team members and our vendor. As such, the tentative election schedule provides for the special election to begin after the completion of voting in the 2021 member-at-large board election. I would also like to mention that in February 2022, we will be seeking board approval of the notice of elections for the state and school member board elections. This would result in some overlap between those elections and the special election of voting period. However, these elections involve separate voter pools than the public agency special election. Based on the tentative schedule for the special election, we would obtain board approval of the notice of election in mid-October, release this notice through public agency employers in late October. Nomination petition period will end in mid-December. Voting will begin in early April and end in early to mid-May when unofficial results will be announced. In the event that no candidate receives a majority of all valid votes cast in the primary special election, a runoff special election will be conducted. The runoff election will involve 2 candidates who receive the highest number of votes. Activities for the runoff election would fall within this tentative schedule. Ballots will be mailed to eligible voters in mid-June. Voting will begin mid-June and end mid-July when unofficial results will be announced. The cost to conduct the special election will be about $500,000 paid in fiscal year 21-22. These funds were scheduled to be allocated in fiscal year 2023. However, if the special election is held as shown in the tentative schedule, the funds will need to be reallocated to this fiscal year 21-22. If a runoff election is needed, the cost will be similar to the primary special election, approximately $500,000. I'm happy to answer any questions you may have at this time. Thank you.
Thank you very much, Mr. Stone, with the detailed information. We looking to see if we have any requests to speak, and I see none at this time. So, very clear report, Mr. Stone. No questions. Okay, so at this stage, we will go to Mr. Fox to see if there are any members of the public who wish to speak to this item. Mr. Fox.
Mr. President, Mr. Stone must have done a comprehensive job. There are no callers.
Okay. Okay, well, good. Okay, so that's fine. Well, thank you very much, Mr. Stone, for the update, and we'll look forward to the report coming for board approval to implement this process. So that completes the second day of our virtual offsite meeting. We'll reconvene tomorrow for the third and final day at 9 a.m. Stakeholders and members of the public are welcome to join us again by webcast. So to all of you and to all of our stakeholders, have a good evening, and we'll see you tomorrow. Thank you so much. Bye-bye.